Hi everybody. Hi morning. Where did where did Lakshmi disappear to? I think we start with who is here. Where is Vidya? I just saw Vidya outside. Oh my god. Presentation is not loaded? Lakshmi, please come up. We have three panelists. We'll start with whoever is here. Right, we have a call Vidya, please, ma. Good morning, everyone. Welcome to day 2 of debate. And we have a workshop. As you know, traditionally, day 2 is a joint, Hall B is always joint gynae related topics, joint between gynae and endocrinology. And we have a series of wonderful gynae related topics. We do need to make sure that we start and finish on time, because one of our panelists is also a keynote speaker and needs to escape at least 2 minutes early to get to her keynote. So, but it's here. So please stay with us for the morning, and let's learn more about obstetric endocrinology. So to kick us off today morning, 9 to 9:40, we have glucose intolerance in early pregnancy, followed by a keynote address by Dr. Umaram, and then thyroid autoimmunity, and then more topics related to obstetrics. So to kick us off for the panel, I'd like to invite Dr. Lakshmi onto the dais, and then she'll take over from here. And
very good morning. Welcome to the second day of debate. And today we start, as Dr. Usha was mentioning, today it is more about obstetric endocrinology and things with reference to glucose intolerance in pregnancy. So the first workshop that we have today is on glucose intolerance in early pregnancy. Wonderful. So, okay, it is my proud privilege to call my panel members to join me on stage, and I'm extremely honored and privileged to welcome Dr. Mohan on stage, and he will be filling in for Dr. Anjana, and I think we are doubly as happy. And though we miss Anjana, we are equally happy that we have been given a wonderful opportunity today to interact with the man himself. And Dr. Umaram, Dr. Muthu, and Dr. Vidya, please join me on the dais. So, whatever suits you, sir, is fine. So this, ladies and gentlemen, we have worked it up like a series of cases, and we would really appreciate a lot of audience interaction, and we have tried to incorporate some MCQ and polls where we take the opinion of the audience sitting here, so that we'll make it as interactive as possible. Dr. Vidya, yes, please come. So the first case, without much ado, I'll start discussing the cases, and these are all very, very simple cases that we see day in and day out in our clinical practice. So I think all of you will have a very, you will be able to add in a lot of inputs, and we are just willing to have a good discussion and learn from each other. So this is a 27-year-old lady, primary spontaneous conception, married 1 year, BMI of 23, and 50 days amenorrhea, UPT positive, family history of diabetes in the mother. Her elder sister had gestational diabetes. So naturally, 1, she is anxious. 2, she is extremely well informed, well read, and she knows the drill that goes into having gestational diabetes. So even as she got pregnant, in fact, she herself does a fasting blood sugar and comes right into your clinic. And she says, because I've seen this in my sister, I'm quite aware. And she comes in with a fasting sugar of 98. So I would just like to open discussion. And first of all, how many of you feel that a fasting sugar of 98 is high to begin with? Is that, yeah, so exactly. So the next question that I would like to pop to the audience here is, what would you do next in this patient? So she is a seemingly uncomplicated case of a very, very normal, uneventful pregnancy, just 27 years old, not very overweight. She comes with a fasting of 98 into your clinic, first pregnancy. what would be your next step? This is a Slido question. You can scan the QR and try and answer this. Why does it not coming? Slido wasn't working. Okay, but my choice is also not coming up. Okay, what would you all do? Do a HbA1c next for this lady, or ask for a GTT, go the traditional method and say, I want a GTT in this lady. Okay. Reassure her and tell her, okay, you're just 50 days amenorrhea, fasting of 98, go back, do some good lifestyle, medical nutrition therapy, come back after 2 weeks, and then we'll reassess. Any hands for that? Fantastic. Ask for a postprandial blood sugar. Because you have the fasting, ask for a PP. Okay. Initiate an SMBG monitoring. You tell her, go prick yourself 6 times a day, 6-point profile, and come back in a couple of days and tell me what the readings are. Is that what anybody wants to do? Well, so I have enough controversy, so let's go in. Why is this? Yeah, sure. I think Dr. Usha said the next speaker would like to wind up early and go to the next talk. I'm going to steal 2 minutes from there, the way things are going. That is exactly what I meant. Yeah, I think we can just start discussing as the Slido gets Sir, yeah.
Can I take the first one? Yeah, I
Please,
think
sir.
there are some slides after that can go on.
It's not moving.
So while the slides are coming on, see, traditionally we would have thought that GDM only occurs in the second trimester, 24 to 28 weeks, and since it is not satisfying the criteria of overt diabetes, which is 126 milligrams, we would have tended to pass on this and say that's okay, it's normal. But right from many years ago, in India itself, thanks to DIPSI, they had already recognized that there are milder forms of glucose intolerance, and not everybody needs to have overt diabetes. Overt diabetic pregnancy means miss the diabetes itself. So that's obviously much more severe. But so let's say we use the same cut points as in a non-pregnant state. Let's say a fasting more than 126 milligrams, 7 millimoles, HbA1c more than 6.5, or a 2-hour value more than 200, or even a random sugar more than 200. These are all diagnostic of diabetes. But there is an entity which is neither normal nor it is overt diabetes. And today we are calling this as early gestational diabetes. This field is fairly new, and Dr. Umaram has been very much involved in the research that we have been doing through many studies, including the STRIDE study as well as a Tobogum study. Now, although people did recognize that, and of course different terms are used. For example, ADA doesn't call it as early GDM, they call it the early gestational hypoglycemia, or something they call it, or abnormal glucose tolerance. But internationally, the term early GDM is now being recognized, which means then you'll have one entity which is GDM in early pregnancy before 20 weeks of gestation, and then after 20 weeks it's called late gestation. It can go on even still later. Late GDM can come even later. Now this classification actually came after the Tobogum study. And the Tobogum study specifically took women with early GDM, randomized them into treatment, no treatment, and concluded in the NEGM paper that treating early GDM is worthwhile. So after that now, many associations have started accepting early GDM. At least 4 countries have now issued guidelines saying that you should screen for early GDM. And I chair the International Diabetes Federation Consensus Group, in which Uma is the other person from India. Both of us represent India on that. 20 countries, 20 people writing a consensus document on early GDM, which is nearing completion, by the way. The last phase is getting over, and we hope to get it published in a very high impact journal. Once that comes and once IDF accepts it, I think the whole world will then accept. Go on to the next slide, because this is HAPO. So from the STRIDE study, which Uma will also talk about when she mentions the risk equation, the STRIDE study was actually started by Dr. Sharavanan Ponusamy, and Uma was very much part of it. So this was done in India, UK, and Kenya. And the aim of STRIDE was not to look at early GDM. It was to look at early pregnancy to see how you can predict late GDM. And we got an equation for that, which Sarah and we have all developed, and Uma will talk about that. So that is what we started it for. But when we did that, we picked up early GDM. And that was a time when tobogam was also going on. So all kind of fitted in, and this just got published in DRCP. Next slide. So I'm not going to go into all this, but through the large screening that we did in India, we had 3,000 women screened, and we had 566 women with early GDM, 359 with late GDM, which we then called as conventional GDM. Now it's called LGDM or late GDM. And we also had normal pregnant women. Next slide. So if you look at the, okay, so probably it'll come to that. The risk factors and all that will come to that. So to cut a long story, getting back to the case that we discussed, 98 milligrams is actually diagnostic of early GDM, because in tobogam, we started right from 92. The original cut point was 92, which was criticized a lot because you're picking up a lot of women with very early changes, which may not be clinically important at all. And tobogam proved that. Tobogam set 2 cut points, one starting at 92 and the 1 hour also lower and the 2 hour also lower, and then a higher band which starts at 95. And it was in the 95 group, the higher band of tobogam, which actually had the most beneficial results. And therefore, in the IDF consensus group, and giving you a sneak overview into what you're going to write, is that in early GDM, we have to use 95 to 125 as the cut point. Now, HbA1c is not useful for a diagnosis of GDM, either late GDM or early GDM, but it's very useful to rule out those who don't need an OGTT, and that's the equation which Uma will talk about. In the slide, we had postprandial blood sugar. Don't use postprandial blood sugar for diagnosis, because postprandial can be idli, dosa, pizza, to whatever, white bread to brown bread to poha to anything. Obviously, you cannot standardize using that. So you have to use glucose if you are using. So what you're proposing in the IDF document is, if you're able to do a GTT, well and good, because that would mean that if it's normal, you'll repeat another GTT in the second trimester, but you can't help it. But those who can't do it, at least do a fasting in A1C. That will help to rule out pre-existing diabetes, and it will also tell you those which are borderline abnormal. And if it's clearly normal, if your fasting is 84 and your HbA1c is 4.9, clearly you're ruled out GDM. So it's still, at least in poor settings, you can at least do a fasting and a HbA1c. But don't do postprandial and all that, which doesn't tell you anything. What does a postprandial tell you? It's not a standardized test. I know there are people who are recommending this, but we don't accept that because it's not scientifically proven. You want to add?
Where do you think of a GTT, sir, in these patients?
Since tobogam was based on GTT, we are actually recommending that a GTT be done, because if the fasting is normal, the 1 hour and 2 hour can be abnormal. And
Yes.
in Indians, outside of pregnancy, the GTT is actually picking up many more cases than the fasting. In fact, I'm part of a pre-diabetes Lancet commission, which is rewriting all the rules for, similarly to the early GDM group. I'm working on another group for the Lancet commission, which is working on pre-diabetes. There we're going to introduce 1 hour also into the GTT, recommending that GTT should be done with 3 samples, not 2. We have always been doing 3 samples. Last 50 years we've been doing that. But now the world has come back to that. So GTT is very, very important, because in South Asians and in certain other ethnic groups, the fasting can be normal, but the 2 hour can be abnormal. So the fasting picks up different type of people, whether hepatic insulin resistance, the 2 hour and the 1 hour pick up, those are the peripheral insulin resistance. So I think both are important. HbA1c is also important. So all the 3 if possible. If GTT is not possible, the lady is vomiting and you're not able to do it, at least a fasting and A1C will help to rule out. If nothing else, at least do a random sugar, because better than doing nothing.
Absolutely.
If you find 300, you know it's diabetes.
at
If it's 70, very unlikely to be. At least that way, extremes it can pick up, but it's not sensitive enough. Anything else?
I think, yeah, maybe when we do the next.
Yeah. Right, we'll continue. We'll speak as it goes, because we have a lot of overlapping points. We'll discuss it as we go through. Now, this is a next patient, a 28-year-old lady, second pregnancy. The earlier pregnancy was 5 years ago. She was a gestational diabetic on insulin, and she had underwent a cesarean section for that. 3.6 kg baby, female baby. Typically, after delivery, she was apparently euglycemic for a while, but like most of our women who deliver, she typically lost to follow-up. So the first 6 months, she was around for follow-up, and then after that, completely lost, and we don't know what happened to her, and she comes back after 5 years, pregnant the next time. Now she's 7 weeks pregnant, fasting 100, postprandial of 128. HbA1c is at 5.5. So how would you actually place this lady as far as stratifying her is concerned? Do you call this early GDM or overt diabetes complicating pregnancy, or does it even matter giving it a name? The fact is that she is hyperglycemic. Just take that idea and go forward. Dr. Umaram.
Okay. So I think really whether it was the first lady who had a fasting of 98 or this one whose fasting is 100, they are demonstrating hyperglycemia in early pregnancy, right? So the evidence, of course, the reason I think you put up that HAPO slide is HAPO showed us that the risk is a continuum. There is no single glucose value below which there are no adverse outcomes and above which there are adverse outcomes. And the committee decided 1.75 odds is where they will put the cutoff, which is why we have 92, 180 and 153 as the IA-DPSG criteria. If you took the 2 times odds, you will have 95, I think 190 and 160 if I'm not mistaken.
Yes, sir. Yes,
and that is what, as Dr. Mohan said, is the high band of toboggan. So basically, that apart, if you had somebody with a fasting of 100, I would stick a label of hyperglycemia and pregnancy, early GDM by the current standards. That A1C is 5.5, which is not diagnostic of diabetes. The postprandial is normal, so she is not, I wouldn't label her as a pre-existing diabetic just based on this value.
Absolutely.
Yeah, she may have had IGT or impaired fasting, we don't know, but she's not over diabetes.
Any differences of opinions? Anybody else wants to add on to that? And you can actually start polling as well. Yes, Dr. Muthu.
I'd probably agree with the same.
Absolutely.
It's basically, we'll go after this, they'll talk.
Yeah, okay. Right. So what would you do for this lady? She has recurrent GDM and she's come in with a fasting of 100 and HbA1c of 5.5, 7 weeks. So how would you like to deal with this lady? Would you ask for a GTT for confirmation? That is a Slido again. And give her a medical nutrition trial and do a GTT after 2 weeks and then risk stratify again at the end of 2 weeks? Or upfront you start on metformin because you are considering that doing nothing is not right, so you want to just start metformin, give it some time, and again stratify her after a while, so that is the next option. Initiate insulin upfront. So what is the, I can see the consensus here, but still we will.
I think from our last case,
this.
it's almost a very similar case. I'd probably go with the GTT before we start anything here. As Dr. Mohan was saying, we'd miss 30% of individuals with postprandial hyperglycemia as well. So a GTT is a good start, and then we can do.
So
that since we have 100 already, that itself even one criteria is enough.
Already
so, and HbA1c 5.5 looks normal, but it's not normal. Our normal is 4.8, 4.9 in pregnancy, and in our GDM group, which we saw in STRIDE, it was only 5.3. So already by GDM criteria, it's already GDM by 2 criteria. So doing a GTT in this case, I think is optional. I don't think we need to, because we already got the diagnosis. If the fasting was normal and the HbA1c is kind of borderline, then we can do a GTT. Here it's clear GDM even by any other definition. So again, doing a GTT here is optional. You would probably start with diet and exercise, see what happens, and after 2 weeks, whether the fasting PP have come down to the levels that we want, not for the diagnostic part, but for the control part. If that's fine, we do that. Otherwise, we have to again decide whether insulin or metformin. Now, the problem is, in early GDM, even toboggan did not randomize into metformin, and they only treated as per the local guidelines of each country. So we treated like that. So we don't know whether metformin is better or insulin is better. Metformin is big controversy in first trimester, but we're hoping to do the next trial, actually randomizing women into this and then seeing. So we don't have the evidence. So whatever is your treatment criteria for GDM, continue that. Vidya, you want to add?
Yeah, those are exactly my thoughts. We already have a diagnosis based on the fasting blood sugar being high.
Absolutely.
We should initiate medical nutrition therapy and then follow them up with self-monitoring blood sugar values, trying to get them into the target for the GDM.
I think the trouble with getting an OGTT really is if that is normal, and it can well be, because we know that GTT can vary from time to time, it's very difficult then to convince these women to stick to diet and exercise.
Correct.
I mean, this is just my, as an obstetrician's perspective. She has had one demonstrable hyperglycemia. I understand that could have been a single one-off. So if you just ask her to monitor SMBG and come back to you and they are normal, you can reassure her but advise her to stick to diet and exercise. What happens when we do an OGTT, they think it, you know, it's
In
all
case it
right,
turns
and then they
normal,
can
they
go
are-
out and eat as much as they want. And then at 24 weeks, if we repeat an OGTT, we may see the hyperglycemia, and the damage in terms of the impact on the fetus has already happened between the 12 and the 24 weeks. So, doctor, yeah.
My concern with a single value of fasting sugar in our country is the biggest thing.
I agree. So I would
So-
do SMBG and not OGTTs.
Right. And the other point there is, if you're putting somebody on medical nutrition therapy, OGTT will not be valid after that. So,
Can I just add to that? So this point about the validity of the OGTT and the repeatability of OGTT has been discussed a lot. In fact, day before yesterday night, we had a 2-hour session in the middle of the night on the pre-diabetes one. So the same thing came up there. So people were saying, why do GTT? It's not reliable and so on. So those facts that the GTT was not reliable comes from data done 15, 20 years ago when pre-analytic methods were very different from what it is today. Today the GTT is very different from what was done many years ago because the methods have improved so much that it's very unlikely that you'll get that much. And first of all, if you're going to do a GTT, I would do it the next day. I wouldn't put her on diet next day. Then we already started the treatment. Then what's the point in doing the GTT after that? Then it's all treatment. The lady is going to avoid sugar and start starving and doing everything. Then there's no point in doing a GTT. If you're going to do the GTT, do it next day if you have a doubt. In this case, it is not needed. HbA1c is elevated, fasting is elevated. 99.99% I can swear that the GTT will be highly abnormal. The 1 hour will be abnormal and the 2 hour will be abnormal. The only question is whether the GTT will come in the diabetic range. Because the 2 hour may cross over to 200 even in some cases. Unlikely with a HbA1c of 5.5, but HbA1c is a very low sensitivity. So we can't go by that. You might actually find that. So in that case, as Muthu said, you can probably put them straight away on treatment of doing GTT. If it crosses 209 or something at 2 hours, then you should start treatment insulin straight away. That is the only indication. Otherwise, for a general thing, just start diet and exercise, repeat fasting PP after 2 weeks and see if at least you have got that. Well, I would diagnose EGDM straight away.
So how important is the history of previous GDM and large?
See, in that particular
important in
case,
this
you
way?
showed a big baby also, which means that earlier itself she has had some abnormality, hyperinsulinemia, so that further adds to that.
So naturally for her, there is no point in waiting too long.
That's right. I think we should,
with a
because 2 weeks
history
is a
like that
long
and a
time in
fasting
pregnancy
being
to wait.
100.
Yeah.
Anything else, Dr. Vidya?
Does that mean like all previous GDMs in the future, or Indians are all high risk ethnic group. When we were in UK, we used to screen all the Indians or Pakistanis at the time of booking.
Yep.
It's only here we were insisting 24 to 28 weeks up until the,
No,
the
but
fasting,
actually the
fasting
DIPSI
and
guideline is
HbA1c.
not that way. DIPSI guideline from 2006
But
has
with
been
GTT.
saying.
With
GTT, yes. GTT
yes.
even now is not actually recommended. Although Tobogum did it, the GTT recommendation has to come now. Once the IDF, but Belgian, Australian, Swedish, German have already said GTT in the first trimester. And IDF is saying the same thing. But we are saying if you can't do it, then at least
Then
you do a
fasting
fasting
and
and HbA1c. So it's going to change now. The guidelines for GTM are going to change.
Yeah, I think doing something is always
Can
better.
I just say that I think the reason, I mean, until Tobogum, honestly, there was no data for GTT in early pregnancy. Whatever we used was an extrapolation from HAPO at 24 to 28 weeks, saying in early pregnancy, insulin sensitivity is higher. Right. Therefore, what is high at 24 weeks will be high at 10 weeks or 12 weeks. It was a physiological rationale with which we extrapolated the numbers. So HAPO's recommendation for early pregnancy screening was to rule out overt diabetes, and therefore they said fasting or HbA1c, isn't it? And when we deduced that, we found women who fell into a category which was not considered normal but not overt diabetes, and therefore this early gestational diabetes is something all of us who have been screening for the longest time at booking have identified. I think with a couple of studies now on treatment and its impact, we have more confidence in saying who we can treat, and we also have some data to suggest who we should not be super strict on.
Right, we'll come to it.
We'll
in the
come to
last
that,
couple
yeah.
of cases.
Can I take this one? Because this is from Stride study. So this is the point I was trying to make. If you look at the HbA1c, and we have two types of HbA1c here, one using a point of care device and the other using a venous, and you can see there's no difference between the two. But look at the early GDM and late GDM. They are not 5.6 and above like pre-diabetic. They are not 6.5. It's just 0.1 more than the NGT and 0.2 more than the early GDM is slightly more. If you compare early GDM with late GDM, and these are the largest numbers published actually in the world, comparing early GDM and late GDM. You can see that the booking weight was more, the booking BMI was more, waist was more, glucose was more, HbA1c is more, venous glucose is more, and venous HbA1c is more. So everything is slightly higher than late GDM. And people who criticize early GDM saying, oh, this is nothing but diabetes which is coming. It's not diabetes. With 5.3, you cannot diagnose diabetes. And look at the glucose, it is 98. With 98, you cannot diagnose diabetes. It's no way. Even if you take the standard deviation, it still does. In fact, toboggan excluded those who had more than 109. Because then that becomes pre-diabetes. Even that was excluded. So this is not toboggan. This is, here we took up to 125. So there is an entity there. And the question is it significant, or are we making a mountain out of a molehill? No, because toboggan showed that treating them even up to 109 was useful. But the other one, if you take too low a glucose, 92 to 95, it didn't reach statistical significance. That is where we are over-diagnosing. And these were the risk factors which we found again in toboggan, that early BMI, pregnancy, HbA1c, and history of GDM, as you said, is one of the things which predicted it.
Look out for. Right, so that brings us to the next case. I think we have 15 minutes more. It will be just right for 2 more cases. So this is a 32-year-old lady, already diabetic, 3 years, on oral hypoglycemic drugs, glycoside 40 milligrams, Janumet and Oxra. And this is her 5th pregnancy, G5, P1, L1 and A3. The first pregnancy was a missed abortion 7 years ago. Subsequently, she had one healthy pregnancy, 5-year-old male child, alive and healthy, birth weight of 2.8, uneventful pregnancy at that point of time. Subsequently, she had 2 first trimester abortions, and diabetes was diagnosed during the second abortion, and she had ever since been on OHAs for almost 3 years now. So this is an unplanned pregnancy, because as we understand, most of our women land up with unplanned pregnancies today. So now she is at 8 weeks. So she just did not expect this to happen, and then she comes into your clinic and she says, I have a fasting of 178, postprandial of 250, HbA1c of 10.8, so it's all out there. So this is typically a case with overt diabetes, 2 miscarriages, already on OHAs, poor glycemic control. So these are all things which are so practically, repeatedly seen in spite of recurrent preconception counseling, recurrent advice that you will have to get your A1C down before you think of pregnancy. Invariably, day in and day out, we have women coming in like this. So I think this is the problem that we face again and again. So for the audience interaction, what would you all like to do for this patient? Stop OHAs abruptly, start insulin, that's about it. There is no second opinion, second thought. Just do insulin and take it from there. But retain metformin alone, maybe just let it have the benefit of metformin. So keep the metformin, but also introduce insulin and keep the metformin on until probably 18 to 20 weeks and gradually withdraw metformin and then keep her only on insulin. Or just not take so much trouble. A1C is 10.8, she's been on OHAs. Advise her against continuation of the present pregnancy. So how many hands will go up for one? Option 1, insulin and insulin alone. Yeah, you can do anything you want, it's your patient. Advise her against continuing this pregnancy. How many of you? At least counsel. Talk to her. What if the HbA1c was 5.5 for the same lady? Would you still advise discontinuation of the pregnancy? SGLT2, DPP4, glycoside. So that brings us to the problem that we have, because today most of our women, even in the reproductive age group, are on drugs like these. So when that is the thing, how prudent should we be as physicians in keeping women on reproductive age group on certain kind of OHAs? Dr. Vidya.
This is a very sad scenario where we have failed at various levels. just from the diabetes point of view, poor control for any age, on 3 oral hypoglycemic agents, and of which one is sulfonylurea. So the first question to ask is the patient's choice.
Yeah.
Does she want this pregnancy? Did she want to get pregnant, or it was just an accident and she does not want this baby?
It is
So
unplanned,
that,
and she says, Doctor, neenga paathukonga na ungala number.
no, that is not an onus on, that's not a responsibility I would take.
Absolutely.
I would guide her in making a decision, but the final decision is hers.
Absolutely.
So does she want the baby or not? If she says, I don't want the baby, then the decision
problem.
is made, no problem. I will still put her on insulin because the control is pretty bad, and then carry on with whatever is needed, to terminate the pregnancy, obviously in the hands of obstetricians. But if she wants to continue pregnancy, we'll have to make her sit, the husband and whoever is involved in her care, and explain to them the risks.
Absolutely.
The risks, some are known because of poor glycemic control, the HbA1c being high. The risk of congenital anomalies is very high, as high as 30%, and explain to them what congenital anomalies are expected and when we can pick them. Some are picked up at 12-week scan, but at 20-week scan is when we can say for sure if the child is normal or not. And if they're happy to wait until then manage diabetes aggressively. That is from the hyperglycemia point of view. They'll have to understand that they're taking a chance that the risk of anomaly is very high. The second, the uncertainties, the unknowns, because the patient is on a DPP-4 and SGLT2 inhibitor, which is not supposed to be on when she's pregnant. There are case reports that the patients have been on these and nothing has happened, but there are also animal studies showing that renal tubular dilatations and some anomalies can happen, which the renal anomalies may not manifest or may not be picked up until 20-week scan. The cardiac and the CNS anomalies can be picked up early on, if I'm right. So the uncertainties remain with regards to the oral hypoglycemic agents the patient has been on. Again, it's ultimately the patient's choice if she wants to take all those chances into consideration and continue pregnancy or terminate.
See, this lady here, she is already a lady with a high cardiovascular risk, previous GDM and recurrent fetal loss, so on and so forth. So technically, you and I would be tempted to keep her on the newer agents. So when reproductive age group comes into being, will you, continue an SGLT2, forget the pregnancy part. What would be your choice of drugs in women of the reproductive age group with a high ASCVD risk? Will you still continue them or keep them on the newer agents like a GLP-1 or an SGLT2?
Yes.
In case they fall pregnant tomorrow, because like I told you, most pregnancies are unplanned. So how would you actually, pitch it in your clinical practice?
I would still manage diabetes like how I would manage in any other man or a woman. I wouldn't discriminate just because she's a woman. I will still put her on the newer agents.
Yeah,
but
exactly.
I would have counseled this woman regarding
Absolutely.
pregnancy, advised contraception, maybe put her on insulin instead of all these 3 agents or 4 agents. She's on metformin, glycoside, DPP-4,
Correct.
and an SGLT2 inhibitor. We have failed at that point. She should have been only on 3 plus insulin. At least we would have, corrected one of the very bad factors, the HbA1c. She should have been on insulin ages ago. We don't know her BMI. If she's obese, she should have lost weight, because all this is going to have impact,
Add up.
maternal and fetal during pregnancy. So I would still put her on OHAs, but I would have advised her contraception, given her good counseling regarding when she can become pregnant and why she can't get pregnant.
Right.
And then, taken it forward. Yeah.
Perfect. Any other comments from the panel, from the...
I think I agree with Dr. Vidya, but most of the time in clinical practice, we find this very, very difficult because most of the time when you ask a woman, are you planning a baby, the answer is no.
We don't know.
No. The first answer is no. And then you ask, are you sure? Then it comes maybe sometime.
Yeah.
And then it turns out to be in a year or 2, and they come back 3 months later with pregnancy.
Totally. I mean, that is the practical
So that
reality.
is where the practical issue arises. And I think if there is a thought of pregnancy in the future, whether it's a year or 2, then we might be cautious as a professional.
Absolutely.
But if patients are, these days patients are very well informed. So generally in my practice, I just document it. We have discussed this.
Right, right.
And the patient is happy to plan fertility after a year or
Right,
so.
I think that's a very good point. To
And
document it and
let it
be
carry
safe.
on from there.
Absolutely.
But Vidya is a lot younger than me. So 10 years back, I was worse than her. But these days, recently we had in the sense being strict with patients and so on, in a nice way. But these days, we had recently a lady who came with a HbA1c of 12 who wanted to continue the pregnancy despite advice, despite at 40. And she's got congenital anomalies. She still wants to continue the pregnancy.
Yeah.
And she is unbelievable. So kind of we have to stick with patient choices these days. And
Correct.
we are treating her blatant diabetes. We are bringing down the sugars. She's doing well during the pregnancy, but this huge risk she's taken with bringing into this world this baby with heart disease due to diabetes is her wish. So a patient's choice matters also in today's world.
No, it is a lot of shared decision making. Ultimately, it's not just one person. I think like Dr. Vidya said, you just have to sit together and make sure that the point is.
And also just keep in mind that an elevated A1C alone, if there are other abnormalities, of course there's no doubt about it. But a pure and simple elevated A1C, I have seen women who have come with 12, 13 go through. We have strongly advised them not to go ahead, but they went there, nothing happened to them. They get absolutely normal baby. I think ultimately
That was my next
Uparwala
question.
decides everything.
I
yes,
just
ma'am.
want to add, yes, I completely agree about patient choice. We counsel about anomalies. If they want to continue, we aggressively get the sugars under control. I think what we forget or sometimes take lightly is their risk of stillbirth remains high, right? So the sugars come under control, baby's growing well. We think they are like any other diabetic mother with diabetes who we can take to 38 or 39. Let's not forget that high A1C, especially if it's 10, 12, 13, and I agree with Dr. Mohan, we've seen enough who manage to have healthy babies, but that risk of stillbirth is quite high, is much higher than somebody who would have conceived with the same duration of diabetes, BMI, blah, blah, but with a good control.
Better A1C.
So that's something we don't communicate to them very effectively.
Exactly. Right, so we'll quickly move on to the last case. So this is a 34-year-old lady, married 7 years, BMI of 30, primary infertility. She is a PCO, takes metformin on and off. Whenever she has irregular periods, she goes to metformin, and she just does it her own style. Sedentary lifestyle. She is on a GLP-1 RA for weight loss prior to IVF, and her gynecologist has recommended that she will be taken up for IVF once she drops a bit of weight. And so the duration that we have in hand is like 1 year or so before weight loss and then subsequent IVF. So when this is the kind of, this is being increasingly seen today with GLP-1s and weight loss medications, I think quite a few of our women in the reproductive age group in the overweight and obese category are on GLP-1s prior to pregnancy. So how would you deal with this, Dr. Muthu? When would you stop? How would you advise further
the
care?
glycemic targets are almost very similar to other patients, be it like normoglycemia, considering all the options, the number of years of diabetes and so on. Near normal hypoglycemia is what we are expecting in these patients. So anywhere between 6.5 to 7 is what we are looking at. The GLP-1 RA is slightly different because these are medications with long half-lives. So we might have to stop them quite early. Not like your drugs which you stop a week or so and then ask them to go ahead with the pregnancy. So the current guidelines suggest that 6 to 8 weeks depending on the molecule what they are on. But there also comes a lot of disruption to the glycemia after stopping these molecules. The rapid weight gain if somebody is not on a good diet and exercise plan. So you have to account this all put together and maybe plan something before you stop the GLP. The guidelines suggest you can say 6 weeks, go ahead, plan your pregnancy, but you have to be ready for all these upsets of sugars, the weight, and so on. So you need to plan it in such a way that the lady has got a stable period prior to pregnancy. Obviously, obstetric concerns in obese women, we all know that there are plenty of them. And by reducing the weight just on GLP-1 RA might not reduce totally. You might have to plan
Yes.
You have to plan to go with good diet, exercise, and other markers to
Right, right.
make that
Absolutely.
control.
And is there a concern with gestational weight gain on people who have been exposed to a GLP-1?
Right.
And how do you actually guide them during pregnancy and around that time?
Right. Anybody who I put them on a GLP-1 RA, they have to be following a strict diet and exercise plan and a lifestyle change. Without it, even in some patients, there is, even without pregnancy, people, the molecule is overridden by their bad lifestyle.
Right.
So we see patients gaining weight, we see patients increasing sugars on these molecules already. So a good lifestyle is essential. The patient needs to get into the habit of eating correctly, doing exercise, and this might be a lot lower if
Right.
that is done already pre-pregnancy.
Right. So I think we have 1.5 minutes left. So let me ask this very provocative question. So at the end of all this, how many of us think that we are overdiagnosing diabetes in pregnancy and therefore putting these women with mild degrees of glucose intolerance in the high risk bracket? How many of us feel that? If none of us feel this, I think our job is done. Oh, wow. Okay, now let's ruffle a few feathers. Yes, ma'am, sir. This will be the closing slide. A couple of slides on the...
Yeah, so
Yeah.
I think, sorry, yeah. So yes, I think there is good evidence that treatment of early hyperglycemia does improve outcome. And one of the studies which, most recent studies, which is an RCT, which looked at this is Tobogum. And it was double-blinded, and so even the treating physicians, we didn't know whether this woman had early GDM or not, and whether she was randomized to treatment or not. And they looked at a composite of birth outcomes, and there was a improvement in the group which had treatment, and compared to those who didn't have treatment. And you can see that the main outcome difference actually came from neonatal respiratory distress in the group that was treated compared to the group that was not treated. And we looked at two subcategories of women, those who had the higher glycemic band, which was the HAPO 2 times odds, those who had much earlier hyperglycemia, diagnosed under 14 weeks, they had the most benefit. So the number needed to treat to prevent one adverse event was 18, which is, very strong evidence that we should treat. But the word of caution, or the thought we should remember, is 30% of women did revert to normal GTTs. Those who went into the placebo group went into normal GTTs. Majority of these had the mild hyperglycemia. So the fastings of 94, and maybe a 1 hour of 181, which again we see fairly often. And there was a trend to smaller babies in the treated group. So when we diagnose a little bit of mild hyperglycemia, we should be cautious, and I would urge us to see how the baby is growing while we monitor these babies. Just a word about stride, because sir mentioned it, if you can go back.
Ma'am, I'm really sorry to interrupt. We had 5 extra minutes. I'm afraid we've eaten into the 5 minutes as well.
So, yeah.
I
think
do
we'll
sincerely
stop there.
apologize.
Sure.
And I will apologize to the audience as well, because if we are to get to the keynote address, may I ask people, maybe the faculty would be kind enough to indulge the audience in maybe 1 or 2 questions at tea time or something, if you don't mind? Thank you so much. So they'll indulge us with that, and I'm going to
Thank you so much.
Thank you. Thank you, Dr. Lakshmi. It's a fantastically important topic. It's something on which no amount of discussion can do justice, frankly. Obstetric outcomes and dysglycemia in pregnancy. If you had another hour, I'm sure we would have filled the time. But this is the time we have, and we must move on. But we have generous faculty. I'm sure they'll indulge us with Q&A wherever we catch them over a cup of tea. I would like to invite Dr. Sridhar, Senior Endocrinologist in Miyot Hospitals in Chennai, to chair our next session. This is a keynote address by Dr. Uma Ram talking about the impact of obesity on obstetric outcomes. Dr. Sridhar, I cede to you.
Good morning to all. I thank Dr. Krishna Sheshadri and the organizing team for this opportunity. We had a fantastic session on GDM. Now the second half, obstetric outcomes. Obesity can affect conception, causes metabolic syndrome, may lead to diabetes, problems in intrapartum, peripartum, and postpartum. Tell us more will be Dr. Uma Ram. She's been introduced. She's a very renowned gynecologist and obstetrician. Over to Uma.
Thank you very much, Dr. Sridhar, and I thank Krishna for this opportunity to speak on the impact of obesity on obstetric outcomes. So I think if we have Slido, with regard to adiposity and pregnancy, which of the following are correct? Adipose tissue expansion is an adaptive response to healthy human. You can answer more than one is right. Subcutaneous fat is associated with adiposity-related metabolic problems. Insulin inhibits adipocyte lipolysis, and obesity and pregnancy are independently associated with insulin resistance. Okay. Maybe we should move on in the interest of time. Oops, sorry. Okay, with regard to BMI categories, which of these statements is true? For every 5 to 7 kg per meter square increase in BMI, preeclampsia doubles. Both underweight and overweight have a higher risk of miscarriage. Women with a higher BMI are at increased risk of preterm birth, and higher BMI increases the risk of abnormalities in the fetus. I don't know if the Slido is allowing only one response. Huh? Is it? Yeah. Actually, more than one is right. And with regard to BMI categories, which of these statements is true? Normal BMI in Asia Pacific is 18.5 to 24.9. There are recommendations for optimal weight gain as per Asia Pacific categories. The most recent recommendation for weight gain in obese WHO is 2 to 6 kg, and underweight WHO is 10 to 12 kg. I mean, this is just to say that sometimes we are not sure what the recommendation is, and we are not telling these women what the recommendation is when they book with us, because we are not setting the expectation right. Yeah? Okay, so this is from the World Obesity Atlas of 25. It tells us what is the risk of lifetime risk of a high BMI in men. And I just want to contrast that with the risk for high BMI in women. And you can see clearly that the women are at much higher risk of obesity than the men are, right? And you can see here that if you look at the prevalence in the end, you can see it's going up like hugely. And therefore, it's not surprising that if we look at the booking BMI of our pregnant women, seeing 30 is not uncommon. In fact, we are seeing 40 and 42 more often now than we ever did even 10 years ago, right? In UK, approximately 1 in 1,000 births were to women with a BMI of more than 50. And in Australia, super obesity has a prevalence of 2.1 per 1,000. I mean, that's a big number, you know. And this again is the prevalence of obesity, how it has increased and continuing to increase. This is from our NFHS 5 data, and you can see that the southern states and then, you know, Punjab probably has your highest risk of obesity. And this tells us what is the trajectory. We can say we are not as bad as America. I mean, this is WHO data. I don't know if we will get American data going forward, but at least until now we have. But India is, you know, also going up quite a bit. And in the UK, when you compared South Asian women to white Caucasians, the risk of obesity was much higher. We also have a much more sedentary lifestyle. And so these are all, so there is some data emerging on obesity, not too much on obesity and pregnancy. So in pregnancy, there is a metabolic change to ensure nutrient supply to the fetus. Earlier on, you have an anabolic metabolism. There is an adipocyte hyperplasia and an adipocyte tissue lipogenesis to ensure that the fetus then gets nutrition. And in mid-pregnancy, this changes to a catabolic state with fatty acid turnover and lipolysis. So adipose tissue expansion is an adaptive response in a healthy human pregnancy. It's meant to ensure the baby gets nutrition. But what happens if you already have too much adiposity on board? Then you switch to this catabolic state much earlier on in pregnancy. And in doing that, the fatty acid turnover and lipolysis increases very early in pregnancy. And while we are all very clued into what hyperglycemia does, we are not that clued into what happens when you have an increased fatty acid metabolism that is happening in pregnancy. So obesity and pregnancy really is fat on fire, because in obese women, adipose tissue may have already reached its maximal storage capacity, and so there is an increased oxidation of excessive nutrients. There's ectopic deposition of fat into metabolic organs like the liver and the skeletal muscles. And we know that lipid metabolism is different in obese women and in lean pregnant women, both in the growth of adipocyte and the distribution. And in these women, they may already have a state of inflammation and hyperlipidemia. And as I said, they shift earlier to the catabolic stage. And all of this sets the stage for a perfect storm. And you have obesity, you have hyperinsulinemia, and you have insulin resistance. And we know pregnancy itself increases insulin resistance for the same reason, to ensure the fetus gets nutrition, right? So when you have all of this happening, obviously you will have increased adverse events. It's a no-brainer. So there is not just the insulin resistance, the fact that there are inflammatory macrophages, the fact that there is a free fatty acid release, which is a pro-inflammatory signal. However, only about 30% of obese women have adverse pregnancy outcome, right? So this is, we have like what we call unconscious bias. When you see somebody who looks big, who weighs a lot, walks in, we are thinking, okay, she's going to have problems. But not all of them have problems. So there is something that makes some women more metabolically prone, and therefore BMI alone may not be a great tool to identify who is at increased risk. So what are the problems? They are at increased risk for miscarriage, hyperglycemia and pregnancy, hypertension and preeclampsia. They are at increased risk for labor problems, preterm birth, problems in labor, because we are more prone to induce them because of their risk for medical morbidity and stillbirth, higher problems of a cesarean section, problems in labor because of labor dysfunction, problems post-op because they are at higher risk for DVT, and also then of future metabolic disease. But within pregnancy, obstetric outcome, these are all our concerns. So miscarriage risk, clearly they have a higher miscarriage risk. So when we look at somebody who's had a miscarriage and look at what is their chance of having a healthy pregnancy the next time, age becomes the highest weightage or important factor. So somebody who's 38 is more likely to have a miscarriage next time than somebody who's 24. After age, BMI is the single most significant predictor. And in the South Asian group, they say high BMI greater than 28, there's a 16% greater risk, and the risk of miscarriage increases to the overweight group and then to the obese group. So this was an interesting study from a recurrent miscarriage clinic where they looked at the impact of BMI, and they showed that there is a U-shaped relationship between miscarriage rate and subsequent pregnancy rate and BMI. Risk was the highest for women who were underweight and those who were obese. And those who were normal or overweight had lower risk. Now, again, if you took away the underweight group and just took those who had unexplained recurrent losses, and you can see that those who were obese had a much lower successful pregnancy rate when compared to those who had normal BMI. And yet, we are very happy to start these women empirically on aspirin and heparin with very little evidence, but don't give them enough advice to lose weight. And I mean concentrated advice. Lip service of yes, you need to bring down your body weight by 10%, which is 9 kilos, does not translate into action on the field. So we need somebody to handhold them besides their own willingness, which I agree. But we all know that women will be most motivated, and it's definitely a teachable moment when we can tell them, if you lose weight, you are likely to have a healthier pregnancy. I'm sure they'll do a lot more, but all of you, I don't have to tell the endocrinologists and physicians how difficult it is for people to lose weight. So they need a little bit more hand-holding. Hypertensive disorders, clearly weight and BMI are both independent risk factors for hypertension. And as I said, for every 5 to 7 BMI rise, there is a doubled increased risk of preeclampsia. And there's good data that women who undergo bariatric surgery, you do reduce the risk of preeclampsia. I'm sure it will show up with time with your medical management of obesity as well, because it's weight loss related, it's not procedure related. And similarly with GDM, again, for every 1 kg per meter square increase in BMI, the prevalence of GDM increases, and it's correlated both to pre-pregnancy BMI and to the gestational weight gain that women have. And clearly the secondary analysis of HAPO data has shown us that maternal BMI independently is associated with pregnancy complications. So if you have somebody who has hyperglycemia and obesity, they have a double whammy because they have two complicated problems. So this is again just to show that whether you look at birth weight, primary cesarean section rate, or the neonatal hypoglycemia or cord blood C-peptides, you can see that the risk increases as the BMI tends to increase. And this plays out also for neonatal body fat and neonatal skin fold thickness, which means that the BMI then impacts the next generation by having a transgenerational impact. What about gestational age at birth? Women who are obese and overweight are at increased risk of preterm birth. This can be induced iatrogenic because they are at higher risk for hypertensive disorders. We want to get them delivered earlier because they have preeclampsia, but they're also at increased risk for spontaneous preterm birth. Why? We don't really know. And there is data for this from the Norwegian cohorts that they are at increased risk even for extreme premature births. Somehow they are also prone for post-term births. So there is a correlation or association between obesity and post-term pregnancy. In population-based studies, the odds are between 1.2 to 1.7%. And therefore, if you take women with obesity and you look at outcomes, you can see here gestational hypertension, preeclampsia, GDM, preterm birth. If you take control to be women with normal BMI, and then you see what is happening with the obese women and what is happening with morbidly obese women, significantly increased risk of all obstetric outcomes. But it's not just morbidity. Actually, they are at higher risk of dying in the perinatal period, and this is borne out both from data from the US and in UK that they are more prone to die. And in the UK, the triennial inquiries into maternal death have shown that more than half the cardiovascular deaths have happened in women who were overweight or obese, and the same thing has been shown in France as well. So these women are more prone for problems. Now, we also spoke a lot about birth defects with hyperglycemia, but obesity itself increases your risk of having a baby with birth defects. It could be NTDs, it could be cardiovascular abnormalities, could be clefts, It could be hydrocephalus or limb reduction anomalies, and this data is from a systematic review that was published in JAMA earlier. Risk of congenital heart disease between morbidly obese and severely obese women significantly goes up. So if you have somebody who is obese and then has diabetes and poor glycemic control, their risk of fetal abnormalities is that much higher. So we need to be conscious of that. Unfortunately, when they come to us, Dr. Sridhar mentioned it actually problems start off even with trying to conceive with fertility. The trouble is when they come for fertility, we don't do enough to make them lose weight. It's also because they are in a hurry to get pregnant. We tell them to wait, they go to some other clinic, and we don't have a national health system where they say if your BMI is above so much, we won't fund you. So there are no drivers to actually make them lose weight. The drivers have to come from us giving them advice on why it is important for them to lose weight. And today we have to be very careful about how we communicate this information, because you don't want to body shame, how do you then say this without making them feel bad is a real problem. And there was a very interesting paper which was published on physician confidence in communicating about weight and gestational weight gain to pregnant women, and most physicians were uncomfortable. They didn't want to address the issue, whether they were consultants or whether they were OBGYNs in training. They simply did not have the confidence, how do I address this weight issue? So I think this is something we actively have to learn to do because it's a fact that we are facing day to day with a woman sitting across the table. So, okay, we said you can, in the panel, we said 12 weeks we can pick up 60% of abnormalities. By 20 weeks we can pick up most abnormalities, right? This is if we do fantastic imaging. Now imagine a pregnant woman who has a BMI of 40 and has so much of abdominal obesity. You keep the probe, you can't see as much as you would want to see, right? In these women, 12 weeks is a better window than 20 weeks because you can do a vaginal scan. And a vaginal scan will give you a much better view of anatomy because the probe is closer. At 20 weeks, you may have lost it. You have to find the windows. And my fetal medicine consultants plead, don't send us 2 or 3 high BMI back to back. Our shoulders go. Because it's really difficult even with a very high-end machine. So we cannot tell them with as much confidence that we can tell you everything is okay. That's the point I'm making. I had a woman who was 122 kilos at booking. I was talking to her about aneuploidy screening. We sent the sample, I called the lab said, ma'am, 120 is our cutoff. If the weight is over 120, I cannot do Down syndrome screening. So this woman says, ma'am, can you please make my weight 119? So I had to tell her it doesn't work, okay? So what do? We offer NIPT. Because non-invasive prenatal screening, we can get fetal cells, it will tell you if you are at risk for Down syndrome, right? So this 38-year-old woman, BMI is, 37, 38, but her weight was, she was tall, her weight was 122. I had to counsel her to say with NIPT, in somebody who has a high BMI, you have a much higher no-call rate. They may not get 4% fetal cells. They may not be able to tell you everything is hunky-dory, right? You're not 26 where I can reassure you and say, actually your chance of having a Down syndrome baby is so low, if the scan is normal, don't worry about it. At 38, I have to worry about it. Both the tests that I can offer you for screening may not give you the answer, and the fetal medicine specialist is going to have trouble doing a procedure as well because of abdominal adiposity. So these are all the additional complexities beyond an actual adverse outcome when we are managing these women in pregnancy, right? Okay, stillbirth, big problem. Risk increases with increasing obesity. This is a very old paper, but it clearly shows us that obesity and diabetes both increase the risk. So I think we have like I said, it's a double whammy in both these women. And this is a systematic review that was published about 10 years ago, that for every 5 increase in BMI, the odds of stillbirth increased 24%. This is the reason why we choose to induce these women and have them delivered by 38 weeks or 39 weeks, because we know that as we get closer to 40, there's a higher risk of stillbirth. So miscarriage, stillbirth, preeclampsia, gestational diabetes, gestational hypertension, all of this you can predict what the risk is going to be at 11 to 13 weeks. Mode of delivery, as I said, higher increase in cesarean section, and good enough systematic reviews that have shown that more likely that their labor is going to be induced, higher chance that labor induction may fail, that progress of labor may be slow, that as obstetricians we worry with a slow progress, big woman, maybe big baby, my weight estimation may be wrong, I don't want to be stuck in second stage and then be slapped with the medical legal suit, I'll section her. If I section her, my anesthetist has a problem, wound infection is a problem, DVT is a problem, right? So higher chance of PPH. We may not be able to monitor the heart rate so well because that pad of fat on the tummy means there's not good contact of the probe, right? And we don't have, all units don't have a invasive internal monitor. Anesthetists are worried, I need a big needle to give spinal. My routine spinal needle will not do. Her airway is going to be difficult. I'm likely to do multiple punctures when I do an spinal or an epidural, and inadvertent dural puncture is more likely. So all of this counseling has to happen. And then we shouldn't forget sleep apnea. We don't even actually ask them about it regularly in the clinic, but we should, because again, they're at higher risk for hypertension. At least if we identify the sleep apnea and correct it, maybe we can reduce the risk. So all of this, and they're also at a significantly higher risk for postpartum depression. So their mental health also has to be looked into. So how can we modify this risk? Clearly, we need to improve awareness, both with the physicians and with the women themselves, because ultimately they have to take responsibility for what their own health. The best time is pre-pregnancy, and also focus on early pregnancy, because the weight gain will start happening after 20 weeks. If between 10 to 12 weeks and 20 weeks we give them enough advice on what is their gestational weight gain, what can they do, then we can probably try and influence. But it's very difficult to influence behavior like physical activity and diet when somebody is pregnant and all the family is saying, she's not eating anything, she's only having 3 idlis, right? Very difficult to change behavior in pregnancy, but at least they may be more motivated. So we looked at our own data. This is about 13,800 odd pregnancies in our practice, and this is the WHO BMI, and if you use that, it's 17%. But the moment we use Asia Pacific, that's the percentage of women who are obese. So 54%. It's quite startling, and we found that all our the numbers, increase HDP, GDM, and cesarean section rate. And what do we do to tell them about weight gain? We just take the IOM category recommendation and shift it down to meet ours. Is that appropriate? We don't know, right? There is no gestational weight gain recommendation for Asia Pacific category based on outcomes in our Asian women. We don't have the data. We have so many births, but we could potentially generate this data. So this is what we do. We tell them, this is the IOM category which we will use for our Asia Pacific category. So we ask the question to look at what is, and this is something that has been submitted for publication, and we find that actually our weight gain windows for a healthy pregnancy outcome seem to be narrower, and interestingly, it is influenced by age. So if you're, and this is something that is not spoken about. So if you're younger and you're obese, you have a slightly more latitude for weight gain for a healthy pregnancy outcome than when you were older. So age and BMI both seem to be having a impact. And I'm not getting into how this, in the interest of time, how this in utero environment can actually affect the fetus. And there is good data beyond birth trauma and hypoxia, how it impacts neurodevelopmental and psychiatric disorders. It supposedly it is known to impact infant feeding behavior and affect leptin signaling in the hypothalamus of the neonate, therefore setting the stage for insulin resistance and adiposity, obesity going forward. So I think we need to do more. What can we do? I think we definitely need to have specialized clinics. We need to have and we need to word them nicely so that women don't feel stigmatized, but they need to get the appropriate advice. We need to screen them early, probably initiate aspirin to reduce PE risk, educate them on gestational weight gain, monitor them more frequently, monitor fetal growth, ensure that they have anesthetic assessment, plan for problems around delivery if morbidly obese, make sure you have a table that can take them, etc., logistics, DVT prophylaxis, mobilization, encourage lactation, and most importantly, emphasize postpartum weight loss, because we know that these women then are at increased risk for cardiovascular abnormality. So I think it's a continuum. If we have lost it in the pre-pregnancy period, we can minimize it in pregnancy, but we should definitely intervene postpartum, because otherwise in the next pregnancy, she's going to come back with even more weight retention and have a problem. So I think I'll stop there, and the answers I think have come in the course of my talk itself. So thank you very much for your patient listening. Thank you.
Thank you, Dr. Uma, for an excellent lecture, showed light on various aspects of obesity. I think, is there time?
We do have 3 minutes, 4 minutes for questions, Dr. Sridhar. So, thank you, Dr. Uma, for a wonderful talk.
I'll set the ball rolling. Now, in non-obese people, other than BMI, we have criteria like waist circumference, because in Indians we are known as the so-called thin fat Indians. So other categories are come. So just BMI alone may not be telling the risk. Do you have any other criteria like
So
that?
yes, I think very true, Dr. Sridhar. Waist circumference, something we have now started to measure. We can do it early pregnancy, but obviously later on in pregnancy we lose that lose the advantage of that. But in early pregnancy, having a waist-hip ratio definitely helps us. In fact, if we go to stride, even waist thickness, waist circumference was an independent criteria that predicted late GDM. And so definitely for the ones who are going in for ART, who come for preconceptual counseling, that's a measure that we can use.
Any other questions?
May I make more of a comment rather than a question? I completely resonate with the statements you made that we are doing too little at present to counsel women prior to pregnancy. But especially I think the opportunity, the biggest missed opportunity is when they present with any kind of a fertility issue, to then go ahead, and this is maybe my perspective is entirely from an endocrine point of view. The frustration comes when someone has already undertaken some kind of assisted reproduction. And we know that the risk of dysglycemia with any kind of an ART is much higher than with a spontaneous conception. And then we are left dealing with the consequences of that. So why isn't everyone looking to themselves, people doing ART of any kind, and then see, you said if I don't do it, somebody else will, so I will. Where is the collective consciousness? Where are the collective, you know?
So, I mean, I
It's
think
really
it's
frustrating.
it is frustrating, it is challenging. I think there are good units which actually do advise them and say, come back. The point is they go somewhere else on their own. Some are very, very motivated, but the pressure, social pressures to have a baby in India is so high. And just as some degree of hyperglycemia is normalized, when you're talking to women with gestational diabetes, they say, oh, but my father's sugars are like this. His diabetologist didn't worry about a fasting of 110. Why are you wanting me to be below 95? So in the same way, a certain weight has become normalized. When we say the BMI is 28, 30, it's not perceived as high. So that perception also has to change, I think.
So once again, I thank Dr. Uma for that excellent lecture. I think due to interest of time, we'll close this session. Thank you very much.
Thank you very much, Dr. Uma, for a wonderful session. And thank you, Dr. Sridhar, for chairing and making it so easy for us. I would like to kick off the next session, which is on thyroid autoimmunity and pregnancy. To moderate this session, I'm going to invite Dr. Leelavati, consultant endocrinologist at VHS and Apollo Hospitals, to come and take over from me.
Good morning, everyone. Thank you very much for inviting to do a panel discussion as a moderator. And I'm very privileged to call my panelist, consultant senior endocrinologist Dr. Usha Ayagiri, and consultant senior endocrinologist Chitra Selvan, and consultant obstetric and gynecologist Usha Vishwanath, and consultant senior endocrinologist Dr. Sri Nagesh. So the session is about thyroid autoimmunity in subfertility and pregnancy outcomes. So the objective of the session is how thyroid autoimmunity impacts fertility, pregnancy outcomes, and neonatal death, to determine when treatment is indicated based on thyroid antibody status, serum TSH level, clinical context in preconception and pregnancy, and also to outline appropriate postpartum follow-up, long-term monitoring strategies for women with thyroid autoimmunity. So I've got questions for the audience. So this is just eye-opener. Following this session, we'll get more details so that we can easily get the answers. So a woman undergoing IVF has TSH 3.1 and positive TPO antibodies. How do you treat before embryo transfer? Okay, so it's 100%. So we'll see if your perception changes after this panel discussion. And the second question, 30-year-old woman with a past history of Graves' disease treated with radioactive iodine 3 years ago presents at 12 weeks of pregnancy. She is clinically well and not taking any thyroid medication. Examination shows no goiter or ophthalmopathy. Lab results, euthyroidism with normal range. She is clinically and biochemically. What is the most appropriate next step in the management? Okay, yeah, it's changing now. So 50-50. Okay. So the answer is monitoring maternal thyroid function test alone is sufficient throughout pregnancy. This is from the audience point of view. Definitely we'll come back to the discussion following the panel discussion. So this is a poll question. Do you check anti-TPO antibodies during preconception in women with normal TSH? So we got the options. So let's see our panel discussion influences the thought at the end of the session. So we know the thyroid autoimmunity is recognized cause of subfertility. In pregnancy, increases the thyroid hormone demand. Women with thyroid autoimmunity have reduced functional reserve, predisposing to gestational thyroid dysfunction. So the session is about recognizing this. Interaction is essential for optimal evaluation and management of infertility, recurrent pregnancy loss, and early pregnancy complications. So now move on to the panel discussion. So it's open to the panel. We have a 26-year-old female planning for pregnancy. TSH is 5.9. How do we plan the management if antibodies are positive or if antibodies are negative? So one of you can, Usha can take the.
Okay. Um, Thank you. This is interesting, isn't it? So if it's 5.9 and planning conception,
Yeah.
I think the consensus would be that most people would probably treat to bring the TSH down, especially if the antibodies are also positive, irrespective of obstetric history. I think irrespective of past obstetric history, irrespective of antibody status, I would treat this woman to bring that TSH down. Now you might ask me, down to what? I would say once on treatment, I would certainly aim for 2.5 for conception and in the first trimester. And if she's already pregnant, similarly, now that's an interesting, sorry, you wanted me to take only the first question, I'll stop at that. So this 5.9, I would treat, irrespective of antibody status, irrespective of obstetric history, I would treat.
So the ATA says if antibody positive, treat, and if negative, to consider treatment. So most of us will treat because it can progress to the overt hypothyroidism.
Strictly speaking, the guideline says consider treatment, but at 5.9, we know that if not now, early pregnancy, her requirements are going to increase and her ability to cope with it is going to be impaired. And I don't want to miss out those first 4-6 weeks when she starts organogenesis at 6 weeks. She turns up at 6 or 8 weeks with a missed period. I think I've lost a crucial amount of time. So I'm likely to err on the side of caution. Have that discussion with her. As we heard in the first clinical case seminar, have that discussion, explain the pros and cons, and probably treat it.
Okay. So if the same woman now got pregnant with the same TSH level 5.9, how do you do with a positive or negative antibody? Yeah, Chitra can take.
Okay, yes. We are clearly going to treat. So I think with pregnancy, we are clear about the TSH targets. The TSH level actually dips down in the first trimester because HCG also has some homology to the TSH hormone per se. So the levels of TSH even in a normal woman comes down slightly. So the upper limit in the first trimester is 2.5. Second and third trimester is about 3. So any value which is greater than 2.5 or 3 in the first, second and third trimester, if you're pregnant, and clearly if it's 5.9, we are going to treat. Primarily because, as Dr. Leela highlighted, the demand for thyroid hormones increases during pregnancy by about 30 to 50%. So women who have subclinical disease pre-pregnancy or in the first trimester are likely to become overt hypothyroidism through pregnancy, and you want to kind of cover the odds and chances of that, and we are clearly going to treat this.
Thank you. So
does Dr. Usha want to add something?
I totally agree with what you're saying.
And some women do have a sudden rise in the TSH level also the minute they conceive. This was the reason why earlier we had this recommendation that when thyroid testing was not so widely prevalent, the common teaching was increase the dose by 30 to 40%. But even though theoretically the TSH levels decrease in the first trimester, women, especially those who are antibody positive, can actually see a major jump in their TSH levels.
So the consensus is.
But this is first time, right?
Yeah.
They are not pre-existing thyroid.
No. Yeah. There is no previous history or clinically euthyroid. So we go to next case. A 29-year-old woman presents with 2 years of primary infertility. Her menstrual cycles are regular and BMI is 23. She has no goiter and no symptoms of thyroid disease. Investigation shows a TSH of 3.9 and free T4 within the reference range and strong positive anti-TPO antibody. This is what the confusion comes. Many of us, like whether to treat, whether not to treat, how do we follow up? So the first question, how should these women be evaluated and managed in the context of infertility, euthyroid, and thyroid autoimmunity. Chitra.
Okay, so the guidelines say that there is no adequate evidence to say that you should treat with this TSH even if they are antibody positive. It recommends that follow them up with a thyroid function test every 4 weeks because they have a good chance of unmasking into overt hypothyroidism. But what happens in clinical reality is that anxiety takes over, especially in the background of infertility and 29 years, and Dr. Oma just told us about Down's risk and how I can't assess risk because window is unclear. All of that takes a role, and in practice, I think all of us have exchanged notes that usually it is started already either by the endocrinologist or the gynecologist involved. And then at that point, you're not going to maybe withdraw treatment. But if you're going to review evidence which is available for anti-TPO positivity and TSH levels, a TSH level greater than 4 and anti-TPO positive, there is evidence to suggest that it makes sense to treat because in them the requirement of levothyroxine during pregnancy is going to go up significantly, so it makes sense to treat. Less than 2.5 anti-TPO positive, clearly no evidence, do not consider treatment. 2.5 to 4, the Walsh and group showed that in anti-TPO positive women alone, if you replace with levothyroxine, some aspects of conception issues and also pregnancy outcomes may be altered, but that evidence is not strong enough to become a recommendation in the guideline. 2 new studies which are not included in the ATA, which is the tablet study, had a separate cutoff. They were 0.44 to 3.7, so Dr. Leela's 3.9 is a very clever question. So even that study went on to show that even at 0.44 to 3.7 with anti-TPO positive, if you treated with LT4, you were not altering chances of conception or pregnancy outcomes. So since we all practice evidence-based medicine and recommendations get followed completely, there is no adequate evidence to say start treatment, but we do know in clinical practice we are likely to start with the understanding that maybe we can stop it after pregnancy and reassess thyroid function. Any other thoughts, doctor?
So actually, when do you stop monitoring this? At what level of pregnancy do you consider stop monitoring the TSH if it's still below 4 and if you haven't started treatment?
So the odds of hypothyroidism developing, maybe after 20 weeks it kind of dips down. Yeah. So if it is, you can check every 4 weeks till about 20 weeks. If it's not peaked, then maybe you can relax it to maybe 6 to 8 weeks after 20 weeks. Autoimmunity itself takes a dip after around 20 weeks. So,
for example, if it's 24 weeks. If you see the TSH of 4.2, what would you do? We get this kind of situation often. They kept on monitoring and they come
the
back.
Guidelines recommend that you do not treat if it is in that range, but we do know in clinical practice we are always likely to treat even though there is not enough solid evidence for that. So that might not be a fully evidence-backed medical practice, but that's what's happening.
Yeah, in the first 2 trimester we consider treat to bring it down. Maybe later on it's just an individual risk assessment and consider. Yeah. So anything to add, panelist, for this question?
No, I agree with Chitra because especially at this stage she may be seeking assisted fertility, and in that scenario it's more likely that we're going to end up treating rather than not, right?
Yeah. I was just going to say that because the 2 years is too short for an infertility, but that's what is the status now.
She's clearly presented for that.
Yes, I think so.
Okay, so to whom should thyroid antibodies be measured and which antibodies should be tested? Do anti-thyroglobulin antibodies carry independent clinical significance? So, to Usha.
So, normal pregnancies, please don't test. That is my first thing. Healthy woman getting spontaneously pregnant, let's not go there, because what are you going to do with just a positive antibody alone if the woman is otherwise well and has conceived spontaneously? They hold virtually no value, and we have no evidence on which to act in that. And I'm saying this because I quite frequently get referrals from obstetricians who've done an early pregnancy antibody and the TSH is completely normal, the antibodies are positive, and then they come for an endocrine referral. And then you're stuck with explaining to the patient that that very scary result of 1000 actually there's nothing I can do about it, and I'm not sure if I do anything about it, how it will influence pregnancy outcomes. So don't measure when you don't need to, because you're stuck with numbers. You don't know what to do with them. In this scenario, I would probably say that if I were to measure antibodies and they're positive, like in this case, it may bolster my case for maybe having that discussion about initiating thyroxine replacement therapy, especially again because she's clearly seeking treatment for fertility or assisted fertility of some kind. So in this scenario, I would probably test, and because it then supports my argument, if I'm talking to the patient, fine, your obstetrician may talk to you about maybe some kind of a assisted reproduction, and if you're going for ART, then getting that down by another 1.5 points may well help with conception as well as with the live birth. So in that scenario, I might. Now, the thyroglobulin antibodies is a personal bugbear for me. I think Chitra also. Because while there is some suggestion that anti-TG antibodies may independently be associated with fertility and pregnancy outcomes, what are you going to do about it? What do you have to modulate it? So the problem then, to me, anti-TG antibodies have a very clearly defined role only in cancer follow-up and management. If you're going to do them outside of that, we are stuck with a scenario where the evidence doesn't support any kind of an active intervention to try. There is nothing we can do to modulate them, number one. And then the patient is left with the anxiety of what are you going to do with a number that you've just told me may influence my pregnancy outcomes, but then you're telling me that there's nothing you're going to do about them.
Yeah.
So it becomes very difficult.
Yeah, so thank you, Usha. So
that's the whole point of this seminar, isn't it? There is no black and white. There are so many shades of gray in between.
Yeah. So the next question, what adverse maternal and fetal outcomes are being prevented by treatment? Dr. Usha Vishwanath.
Before I come to that, I think like Dr. Usha said, if I didn't see the word primary infertility here, and she had a strong antibody positive, but with normal thyroid function, we wouldn't be actually treating her. We just monitor her thyroid functions. But when the words infertility come, they want the optimal values there, and only then the outcome of ICSI or whatever ART they go ahead and do will have validity. Now, adverse outcomes, both maternal and fetal by literature, there are two outcomes that we ask our students to tell for any high-risk pregnancy, and that is miscarriage and preterm labor. We say, if you don't know the answer, please tell these two. Mull over that, then you will get the rest of them. So miscarriage, preterm labor, then of course we have low birth weight, then fetal growth restriction, and because it can affect the placental functions, we have to consider higher incidence of GDM and preeclampsia. Then of course postpartum thyroiditis is another possibility to be kept in mind. And the teaching is that there can be some neurodevelopmental problems, but to be very frank, in practice, I don't think we have ever seen, even with very large values of TSH and high strong antibodies.
Okay, thank you.
Thyroid has always been kind to us as obstetricians, I should say.
So we actually, the next question we already discussed, is the levothyroxine indicated in this women? What TSH target would be used while attempting consumption and during pregnancy? To Dr. Srinagesh, should levothyroxine be continued if already started on during pregnancy following the delivery?
Yeah, the first part, is levothyroxine indicated in a perfect world? No. In an actual world, yes. Because, not only because of the reasons presented by my colleagues, let us just assume that patient has a primary infertility, she had an ART, she has an abortion. It might be because of APLA, it might be because of PCOS, it might be because of many things, but you'll hear only one answer, it will be because your endocrinologist did not start you on thyroxine. For the next 10 years, you'll be blamed for that. Better play safe, start her on thyroxine. Second, targets generally we'll go with, we should actually be going with population-based targets, but we'll go with 2.5 in the first and 3 in the second trimester, which is universal. Continued after delivery, postpartum thyroiditis. Generally, somebody with this kind of a picture will usually be only on 25 or 37.5, maximum 50 all through pregnancy. After delivery, I would definitely stop thyroxine because postpartum thyroiditis, especially in somebody with TPO positivity, is a clear and present danger. And we need to monitor. What's more important is monitoring because we get so many patients in the OP who have a complete remission immediately after delivery because of postpartum thyroiditis. They assume they are euthyroid and they'll come back to us maybe a year down the line with a TSH of more than 100. So we will have to monitor. I wouldn't continue, but I would definitely monitor this patient.
So actually between 2.5 to 4, if someone considering ART or recurrent pregnancy loss, the ETA and ATA guidelines says consider treatment. In other situation, we don't have to treat even if the antibodies are positive. There is no evidence to say we have to treat. Yeah. And then if it is negative, obviously we don't treat. So that is the summary of all the panel discussion today. And so we'll move on to the next question. We have a 36-year-old woman with tubal factor infertility is scheduled for her first IVF cycle. She has regular periods and no symptoms of thyroid disease. There is no goiter. She has had one failed embryo transfer. Baseline investigation show, again TSH 3.4, free T4 within the normal range, antibodies are positive, AMH and pelvic imaging are normal. So how does thyroid autoimmunity affect IVF success beyond thyroid hormone levels? And does it primarily impair ovarian response, embryo quality or implantation? Dr. Usha Vishwanath.
Actually, IVF, when women go for IVF, they do the AMH because that is one of the primary things they look for. And they also look for a thyroid function test along with the antibodies as a screening method when they go for IVF. That's what has become the order of the day now. Now, very, very small studies have shown that it can impair the retrieval rate or the quality of embryos or implantation. There is a theoretical risk that these autoimmunity can affect the mitochondrial part of the embryo. And the European Association guideline says if they are doing ART to go for ICSI, intracytoplasmic sperm injection, because the contention is the antibodies will be bypassed. So it may not affect the zona pellucida of the oocyte. But majority of studies say it doesn't really affect the clinical pregnancy rates in a very, very significant manner. So either retrieval wise or the quality or implantation is not very, very significantly altered, except for very small studies which have shown.
Okay. Yeah, thank you. The next question. Should women with thyroid autoimmunity undergoing ART have different TSH targets than those attempting spontaneous conception? If yes, why?
It's a very tricky question because what different targets do you want? Do you want a TSH below 1?
Yeah.
You cannot have different targets. So it has to be a target of 2.5, be it somebody who is autoantibody positive or autoantibody negative. Because it's very difficult to explain to a person who says, I've got a TSH, even when the TSH is 3. Sometimes 3 or 3.5, it becomes a problem to us explaining to them that they have to be started on thyroxine because they have a TVO positivity or they have a bad obstetric history. If you look at the guidelines, they actually say that if somebody has a bad obstetric history and who is TPO positive, even if the TSH is 3, they can be started on 25 or 50 micrograms because there is no harm. They don't give you evidence. They only actually use the word there is no harm.
Yeah.
But explaining it to the patient, somebody whose TSH is normal, it would be absolutely perfectly fine. Telling them that you have to use thyroxine is difficult. And then lowering the targets even further for somebody who's actually autoimmune will be even more difficult. And the second thing, if you have actually looked at, I think there was a study published a decade ago in PLOS One which looked at rabbit outcomes. It was actually an animal study because you'll have to go back. TPO antibodies, generally, this is our understanding that they do not have a role in basic thyroid disease. They are only surrogate markers. Perhaps the only place where TPO antibodies have a direct role is in bad obstetric history and risk of abortions. This is also proof of concept. And increasing thyroxine dose so that the TSH levels cutoffs come down has not been shown to improve the outcomes in these animal studies. So the TPO antibodies directly are causing that, and anyway we do not recommend using glucocorticoids to bring down the TPO antibodies. So I don't think we need different cutoffs. And the other thing is, all the data and the ETA guidelines have come from the work of one single person, Negro. And there are many methodological flaws in the paper he published in 2010. And that has actually skewed our entire understanding of hypothyroidism, subclinical hypothyroidism, and the TPO antibodies. So I am not in favor of this.
Yeah, so even if you are starting, we aim preconception below 2.5 and trimester specific ranges in pregnancy. Okay. So should levothyroxine be initiated before ovarian stimulation in euthyroid anti-TPO positive women? And what evidence support its effect on implantation and live birth rates after IVF? Dr. Usha.
I really want to say the evidence is the court of public opinion, because once or twice something doesn't succeed, they'll come back. Both the patient and the obstetrician will come back to focusing on those antibody positivity. So, okay, all jokes aside, does it affect ovarian stimulation? No, it doesn't. But can it affect implantation and live birth rates? It may. The TPO positivity. In someone who has negative obstetric history, as Dr. Nagesh has said both in this answer and in the previous answer, I think most of us would err on the side of caution, also because we know that there is no harm that we are causing should we choose to start a small dose of thyroxine and bring that TSH down to, hers was 3.4, down to 2.5 or less. I'm not causing any harm. I may be protecting my practice. Chitra is laughing, but true. Because if it is, she's had one failed IVF cycle already, right? Or did she have a...
Yeah, one embryo transfer.
One embryo transfer didn't
Failed,
succeed,
yeah.
right? So in that scenario, in this woman, I would probably be... And the reason I would start it before ovarian stimulation is simply because if the interval between the stimulation and the implantation is shorter, I really won't have time to catch up in between. So I may err on the side of caution and say it's not going to affect the stimulation, but if you're going for an implantation within the next 1 month, that will give me a little bit of lead time to get your TSH down in time for the implantation. Otherwise, if the implantation is postponed, yes, you can get your oocyte harvesting done and then come back to me 4-6 weeks before you plan implantation, and then we'll deal with your thyroid TSH levels and autoimmunity. But mostly sometimes I think we do it to keep our obstetric colleagues happy, because we know that they are happier when it's 2.5, and it does affect implantation rates and it can affect live birth rates. And then of course once the patient has this implanted in their brain, whether the oocyte implants or not, that idea of that TPO positivity and maybe outcomes being related to that is then firmly implanted. So these are gray areas.
It's usual that before we get the patient already on levothyroxine, and so yeah.
I just want to add, it's extremely debatable, like you said. But then when we are like smothered by that infertility and patients are so anxious, I think we will err on that.
Okay. So we'll move on to the next one. Should immunomodulatory therapies, steroids, IVIG, intralipids be used in euthyroid women with thyroid autoimmunity undergoing IVF? Chitra.
I think this is a very important question to ask. So while we might have been going on and on about, although the guideline says this, we still do this. This is one area where we should be clear about the fact that there is no role or use of steroids, IVIG, or any of these other methodologies to target autoimmunity per se, or track the anti-TPO levels. If you look at the international guidelines, they might talk about iodine supplementation. We don't have to worry about that because we have a national iodinization program. So we are all considered iodine sufficient because all of us have iodine in our diet to meet our adequate requirements. The other point which has been tried to some extent, which might be innocuous, might be selenium supplementation, but absolutely no role for steroids or IVIG, which is still a practice which might be tried in some situations where artificial reproductive techniques are being tried and used, but there is absolutely no evidence. It can significantly increase the odds of blood sugar, blood pressure, weight, and also immune suppression if you give it for a few days and withdraw suddenly. So for this we have a clear answer, Leela.
Yeah, you're true. There is no evidence to support.
Have you seen
this.
intralipid?
Yeah.
Have you seen use of intralipid? I have seen it just 2 days ago. I had a patient who was brought to me with intralipid. The last time I saw intralipid used was in my neonatology posting. Then she comes and just for bad obstetric history, she is given intralipid.
Interesting.
And now her blood glucose levels have gone up because she was a pre-diabetic.
I've seen only, like, heard only in clinical trials they try all this. Yeah. Okay. So, another.
I mean, exactly what does it change?
The titers will come down and then go up.
Exactly. You're transiently suppressing a titer that is then going to revert by the time you're actually doing anything. So to what end?
Yeah, there is no improvement in the pregnancy or neonatal outcome with these medication. So actually, it's another question open to the panel, like during ovarian hyperstimulation, because of the SHBG changes, we have the fluctuation in the TSH. So already Usha has mentioned that we'll do well ahead for the implantation to work. So if it's ovarian hyperstimulation, when do we check the TSH is the question, because it can affect the TSH level. So the literature says 2 to 4 weeks before starting stimulation and aim for TSH below 2.5. Yeah, okay. So we said no clinical evidence, and we'll move on to case 3, it's Graves' disease. So we have 28-year-old women at 10 weeks of gestation with palpitation, heat intolerance, and weight loss. This is her second pregnancy. The first ended in spontaneous miscarriage at 9 weeks. She has no previous diagnosis of thyroid disease. On examination, she has a pulse of 112 per minute, small diffuse goiter, and mild lid lag, but no ophthalmopathy. So we have a laboratory test, free T4 2.6, TSH less than 0.01, TSH receptor antibodies are strongly positive, anti-TPO antibodies are positive, ultrasound confirms a viable intrauterine pregnancy. So the questions, number 1, what is the role of TSH receptor antibody measurement in predicting fetal and neonatal thyroid function test in Graves' disease, and should TSH receptor antibody be measured in all pregnant women with a current or past history of Graves' disease? Dr. Usha.
I'm going to answer in the reverse order. Yeah, I'm going to answer in the reverse order. My short answer for all pregnancies is yes. If you have a woman with past Graves' thyrotoxicosis, I would say measure. Leela, I was just going to say before we go on, we need to stop in about 4 minutes if you want time for questions, or finish the 9 without questions. So, yeah, because I was just watching the clock. So in all pregnancies where the woman has had previous Graves' thyrotoxicosis, I would say yes, we should measure. The reason for this is TRAP crosses the placenta. Irrespective of the current maternal thyroid status, measure once in early pregnancy and once towards the second half of the second trimester, 20 weeks plus. And the reason for this, as I said, is because TRAP crosses the placenta, and the things you're looking for, and I specifically write it and give it to the sonologist on my request forms for ultrasound, I ask them to monitor fetal heart rate and to look for fetal goiter. Because this TRAP that crosses the placenta, even in the mother, if it's not doing anything, maternal TFTs are okay, it can still cause fetal thyrotoxicosis. And the way to pick it up during pregnancy is actually fetal heart rate monitoring and to look at a fetal goiter, because that can then have implications for delivery if there is a fetal goiter. So the short answer for part B is yes, and the long answer is because. Right?
Anything panelists would like to add? Otherwise, we'll move on to.
I think in the case scenario that you've mentioned, that first trimester, TSH being suppressed, free T4 being high, one of the DDs is it gestation thyrotoxicosis, or is it Graves, or is it thyroiditis? In that situation, it is of diagnostic value. Yeah. So if you have a TRAB positive in this scenario, you're very likely looking at Graves. In the general population, TRAB antibody positivity is very low. So if it's positive, you could potentially make a diagnosis of Graves, because in this scenario, nuclear imaging to make a diagnosis in pregnancy is contraindicated. So that's another use of this measurement, apart from the monitoring advantage.
Yeah. So then I'm going to ask Chitra a question. Will you treat the mum at this stage? Go back to the values on the previous slide. Yeah, heart rate and free T4. Will you treat her?
Yeah. So the recommendation is to keep free T4 in the upper 50% or the centile of the free T4 levels, not the TSH in this context. So since she is symptomatic and the free T4 is elevated, we would be starting her on a small dose of medications. Since she's at 10 weeks of gestation, probably we initiate with propylthiouracil, shift over to methimazole as the pregnancy progresses.
Yeah.
We should be cautious here, not to overtreat and to maybe follow up free T4 in 2 weeks' time to make sure we are not over suppressing and titrate down the dose or switch over to methim as quickly as possible.
Yeah. So, and even if the clinical thyroid function is normal, then we still do a TSH receptor antibody, as Usha said. Okay. So, the next question, how should TSH receptor antibody levels be used to guide fetal surveillance, including ultrasound monitoring for fetal goiter, growth restriction, and fetal heart rate abnormalities? The level of TSH receptor antibodies.
Yeah, I'll take the first part. I think most of the second part's been answered. The TRAB levels may be a diagnosis to know whether you're looking at a case of Graves or gestational thyrotoxicosis. And ideally anywhere between 22 to 26, because I see a fair amount of neonatal endocrinology, and that particular TRAB titer at 22 to 26 has been a very good indicator of neonatal thyrotoxicosis.
Okay.
Monitoring, as Usha ma'am has said, heart rate is very important. In fact, in situations like in a government college when we were students, when people couldn't afford TRAP, and you had a question as to whether this was gestational thyrotoxicosis or Graves. Because generally the thyroid hormone levels dip in the second and third trimesters, even in Graves, because you have a remission. If the fetal heart rate is above 160, in all probability, even in the absence of a TRAP test, you're probably dealing with a case of Graves.
Yeah.
And you should sometimes treat the mother because the fetal heart rate is more. This is one of those very rare cases where you use the obsolete method of block replace.
Thank you. So, the next question, how should this women and her fetus be monitored throughout the pregnancy to prevent maternal and fetal complications? How does this differ in a woman previously treated with surgery and radioactive iodine?
See, as far as the obstetrician's perspective is concerned, the woman and the fetus are going to be monitored pretty much the same, apart from the thyroid monitoring that's going to be happening. So we usually do an ultrasound, which is viability, where we record the fetal heart rate, and then we have a NT scan at 11 to 13 weeks. We'll probably be doing a fetal echo. We do a screening maternal echo for all patients now, and then the screening and treatment during antepartum is pretty much the same. And NST is something that we would probably be doing after 32 weeks, maybe a couple of them, to make sure that the fetal heart pattern is absolutely normal. And as far as intrapartum is concerned, I think she will be managed very much the same like anyone else. If she needs to be in spontaneous labor, there is no role for any inductions, no need for any operative deliveries. I don't think there is any difference. It's pretty much the same.
Okay. So the next question, when and how should neonatal thyroid function be assessed in infants born to mothers with current or previous Graves' disease?
I'll invite Sri Nagesh to answer because he's the pediatrician.
Ex-pediatrician. I've forgotten my pediatrics. So I generally monitor it around 3 to 5. Anyway, most hospitals do an antenatal screen, but the additional thing I do is repeat it again at day 15. Because I see some children who are picked up on day 15. It has never lasted beyond 70 to 90 days. I've seen many cases of neonatal thyrotoxicosis. The worst would be 90. After 90, you continue on thyroxine, they generally go into hypothyroidism. You've got to be frequent with monitoring. Another caveat is generally people actually tell you an year or two after somebody has received radioactin, the antibody titers go down. That's not true.
Okay.
I have seen antibody titers persist in people who have received radioactin even 5 years earlier.
Yeah.
They can be very high, and you will probably need to monitor them for close to a decade.
With the surgery, do you think the antibody titers comparatively lower?
Yeah, surgery obviously they'll be low because you don't have an antigen, but nobody goes in for surgery nowadays.
Okay. And how soon do we need to test for neonate following the delivery for thyroid?
Mine is 3 to 5. First one is 3 to 5, and again I always repeat it 50 because there can be people who have a late rise in the T4 levels.
So the both antibody and antithyroid medication influences the thyroid function. So as we said, we closely monitor the baby and see whether the thyroid function getting resolved. So this is just briefly summarized. The important thing, TSH above 4, we treat preconception and during pregnancy. Between 2.5 and 4, we may consider treatment in recurrent pregnancy loss or planning for ART. And in pregnancy, we try to bring the trimester specific reference range by treating the patient. Similarly, with TSH 2.5 to 4, we treat and bring it down below trimester specific reference range if the antibodies are positive. So just close, yeah? And
So actually we are going into the coffee break, and I think we are back from the coffee break. Gauri, whatever is the next session in this 11:10. So if there are any burning questions, we can maybe spill over 5 minutes into the coffee break if anyone wants to. Okay, then I think everybody wants coffee. Nobody wants to sacrifice the tea coffee.
so thank you, Chitra, Usha, Dr.
In fact,
Nagesh, and
I
Dr.
can
Usha
see Dr.
Vishwanath.
Lakshmi going grr grr at me when I said people want to give up coffee break.
And also, I hope you got the clarity of the answers for the MCQs by the end of the session. If anything, kindly ask us. Thank you.
Now we will move on to the debate. For the debate, metformin should no longer be recommended in pregnancy. May I request Dr. Shanmugam sir to come over to the stage, and I request both the speakers, Dr. Sri Nagesh and Dr. Chitra Chelvan, over to the dais, please. I request Usha Vishwanath madam also to come onto the stage, please. I'm sorry.
Good morning, everyone. It is a never-ending debate we are going to have. This debate going to be there another, hope, some more years together, even though we have a debate time here. So metformin should no longer be recommended in pregnancy. We have two eminent speakers for the debate. Dr. Sri Nagesh is going to talk on you should not give, and Dr. Chitra Selvan is going to talk. Absolutely, yeah. Yeah, absolutely. So I request Dr. Sri Nagesh to give your views. So over to you. Dr. Sri Nagesh is a adult and pediatric endocrinologist and diabetologist from Sri Nagesh Diabetes Thyroid Clinic, Hyderabad.
Yeah, thank you, sir. Thanks for the introduction. And before I begin, I'd like to thank Krishna Seshadri sir and Dr. Sanjay Reddy for inviting me here. I think it's only my second time in debate. So generally, when this kind of lectures start, it usually goes along this script. I give you a lot of points which are in favor of metformin. You listen to them. My opponent comes over, and she'll usually start with the standard dialogue. I'll thank Sri Nagesh for making my job easier. This is the usual script. In every debate, this is the script. So I'd like to change it better, and I'll take it a little bit further. And for the first 3-4 minutes, I'll speak for Chitra. I will tell you why you shouldn't use metformin. If anybody's ever read Dante's Divine Comedy or La Commedia, you would have seen that there are 9 circles of hell. And all these 9 circles of hell will actually correspond to what most people perceive metformin use in pregnancy to be. You have 9 problems with metformin which correspond to the 9 circles of hell. Most of the time, one of the commonest signals, the first circle of hell, the least circle of hell I tell you is that you got a childhood adiposity signal. Higher BMI is seen in offsprings on follow-up, something based on what is called as a Barker hypothesis. The basic assumption runs this way with metformin. Generally, when you give metformin, we always know that many people, when we did not have any anti-obesity medicines, metformin was used as an anti-obesity medicine. The same way you are giving metformin, which does cross the placenta, goes to the fetus. The fetus is lean when the child is born. They are usually small for gestational age. Once they start growing up, to compensate for what they've lost in utero, they start adding on the pounds ex utero. And this is what actually in the long term contributes to adiposity in the fetus. Most childhood follow-up studies have actually shown higher BMI Z scores in exposed offspring. Basically, this is what metformin does. It leads to metabolic programming. And this is what contributes to higher fetal adiposity and risk of diabetes later on in life. Second, any molecule which crosses the placenta freely can pose problems to the child. You got an unrestricted placental transfer. Metformin freely crosses the placenta, acts on the child, and concentrations are similar to the maternal levels. This is mediated by organic cation transporter, so this is a facilitated diffusion. And these mTOR pathways might be affected during the fetal development, and this might have effect later on in the fetal obesity and the fetal metabolic parameters. One of the strongest signals, arguments we have against metformin, especially in the first and the second trimesters, is higher small for gestational age data. Children are generally born smaller, something to the tune of 60 to 100 grams smaller than children of a corresponding insulin use. And it is this lower birth weight which is actually imputed to cause all the problems which happen later on in pregnancy. And these problems in pregnancy, which occur because of metformin, also program the fetus in such a way that the fetus later on in life ends up becoming an obese diabetic. Especially in settings where fetal undernutrition is a problem. This perhaps is the single largest problem which goes on against metformin. Some of these meta-analyses have actually shown a signal towards preterm birth. There is one large randomized control trial which showed reported lower gestational age at delivery with metformin, higher odds of preterm birth versus insulin. That is the reason why many gynecologists will actually tell you that insulin is the drug of choice even in the first and the third trimester. And these were open label trials. The fifth one, generally some women are actually given metformin right from the first trimester when there are cases of PCOS. There have been some signals that it reduces the risk of preeclampsia and this also reduces the risk of GDM. But long-term data have actually never shown that giving metformin early on in pregnancy prevents your GDM. So why are we actually giving metformin in the first trimester when we are unable to prevent GDM? Long-term, of course, one of the biggest arguments we know is we've got 6-year data, 7-year data, 9-year data. We don't have long-term data. So we know that till 9 years of age, the child is not going to develop diabetes. But will this prevent the child from developing diabetes when the child is probably around 30 years old or 35 years old? Until and unless we have this kind of data, we cannot actually endorse metformin in pregnancy. And then most important, we got mechanistic worries. Even today, we don't really exactly know how metformin works. It acts on the mTOR pathway, AMPK and the mitochondria. All these could lead to other problems, even risks of cancer or other disorders later on in life. This I think would be mostly what Chitra would say. So now that we've gone through hell, if you read Divine Comedy, you know that you start with hell, but you eventually end up only in paradise. So in the next 3 minutes, I'll take you through to paradise. The journey never ends in hell, it only goes through paradise. This is what contains. Generally, when you actually look at the adiposity signal, the earlier studies actually reported more adiposity in children who use metformin later on, but the recent meta-analysis have not given such great signals as far as adiposity is concerned. Most of these are in the PCOS trials. People generally make this mistake when they are using metformin. We did not have a large amount of studies for metformin till you had the metformin MIG study. All the data we've had early on as far as metformin use in pregnancy is concerned has come from the PCOS studies. Their primary endpoints are different, the secondary endpoints are different, and we all know that the fetal weight, the single most important factor for the fetal weight is maternal weight. The maternal glycemia is the second most important factor. A lot of these children who were born large for age were actually born to large mothers, and this was what more likely influenced the children becoming obese and having diabetes later on in life than the fact that they were given metformin in the first and second trimesters. Most follow-up studies in women with GDM who were given metformin have actually reported neutral weight gain. And this might be context dependent rather than being an absolute value. You cannot actually say that every child who's been given metformin when the mother was pregnant ends up becoming obese or ends up getting diabetes. And second thing, even though you got a placental transfer of the drug, this is not always bad. In fact, this is one of the best things you can get with metformin. What harms the fetus is hyperglycemia. It is not transfer of metformin across the placenta. And what metformin is actually doing is preventing this transfer of maternal glucose across the placenta and causing fetal macrosomia. And you are unlikely to have a neonatal hypoglycemia in this case. Because as a pediatrician, we actually used to see a huge amount of children who were admitted with neonatal hypoglycemia because the mothers were treated with insulin, which was usually inadequate because they were insulin resistant, ended up with the ICU. fewer larger babies. Actually, it does not cause small for gestational age babies. It actually causes an optimization of your gestational age, which can be a huge win as far as these women are concerned. This is often neglected. Preterm birth, again, the evidence is mixed. Most of this data is extrapolated from PCOS. If you actually look at the studies, the newer studies actually do not give you a signal for preterm, and the preterm birth which you get is actually only 3 or 4 days, never more than that in most of the studies. Benefits are most defensible in PCOS. In fact, women with PCOS, they will not have prevention of GDM, but they will always have improvement in obstetric complications. And this is where we actually use metformin in PCOS for the maximum benefit. We are not looking at preventing GDM, we are looking at preventing the complications of GDM. Large registries, we've had huge registries over the past 10 years, and most of these registries have added a large amount of data to us, which reassures us as far as the safety of metformin is concerned. I'll just finish in less than a minute. Metformin reduces maternal weight gain, and we all know that maternal weight gain is what is most important for fetal outcomes as well as outcomes later on in life, including the Barker hypothesis. And most analyses have actually shown less gestational weight gain and lower pregnancy-induced hypertension. We all know that metformin prevents pregnancy-induced hypertension, and women obviously will prefer oral and cheaper oral therapy and more convenient oral therapy over insulin. Patient choice is the most important thing, because the minute you start somebody on insulin, many women have apprehension about taking insulin, they have reluctance to taking insulin, and insulin can be dangerous in a few women. And sometimes we start with doses which are as ridiculous as 2 or 3 units. Rather than going in for these kind of doses, it's always better to put them on metformin, which is backed by a huge amount of evidence. Not just because it is convenient, because it is convenient and it is proven to be safe. At the end of the day, what is happening with metformin is that we've got an unnamed fear of using metformin. And it is this fear which has actually prevented large-scale use of metformin, even though the data is staring us in the face. And it is high time we wake up to the reality that metformin is here to stay. To conclude, we know that metformin crosses the placenta, but this is actually one of the benefits of metformin rather than the harms. Short-term outcomes actually tell us that metformin is beneficial. Long-term outcomes, at least till 9 to 10 years of age, have not shown any harm. And do you really expect that we'll need to wait for another 50 years before we actually conclude that metformin is useful in these people? I don't think we can wait for so long, because we'll be losing a few decades of benefit. So best practice in this case would be to take a via media path, individualize, and always make it a point to use a low dose of metformin, because the majority of women who present with GDM are actually insulin resistant. And just pumping in insulin alone into these women is not going to help them optimize their blood glucose levels. That's it. Thank you.
May I now request Dr. Chitra. Oh, she's going in that mood.
Before they put the slides and my timer starts, Sri Nagesh is a pediatrician. Okay, so his heart is always with a child. He's a pediatrician who's trained to be an endocrinologist. So it's great that although his topic was to speak for metformin, his heart did not allow him to argue for metformin, because he knows there is no evidence towards that end. Okay. So thank you so much. Okay, but I'm going to zoom back out completely. Okay, this is not a debate about whether we should be using metformin or whether we should be doing insulin. It is about for us to recalibrate and understand why we are doing what in pregnancy. And a lot of information has been added to the management of hyperglycemia in pregnancy. And we will spend the first 2 minutes just setting the context. I'm very acutely aware that this is a hall filled with gynecologists, okay? So I'm going straight back to the HAPO study, okay, for you to refresh what it was. A study which looked at hyperglycemia and pregnancy-related outcomes. Large group of women looked for primary and secondary outcomes related to fetal and pregnancy outcomes. But pay attention to the categories of the blood sugar levels. Fasting of 75, 1 hour of 105, and 2 hour of 90, okay? And when they looked at outcomes, only thing you need to know, don't read, look at the trend, okay? The results showed that there's a strong continuous association of maternal glucose levels with adverse neonatal outcomes, okay? That's very, very, for the first time we learned that the blood sugar levels or what we do to glucose levels can affect neonatal outcomes. And also, we now have follow-up data. All those children are now 9 and 10 years of age. So this is one of those studies, 14-year-old kids, call them in for a GTT.
your maternal glucose levels when your mother was pregnant with you is highlighting your risk of having impaired glucose tolerance when you are 15 years of age. Prevalence is about 10% or so. 10% at age group of 10 years is not a joke, okay? Similar studies which has looked at body composition. Please again pay attention to the values we are talking about. Fasting values of 75. So 2 units of insulin is not a joke. 2 units is necessary to bring the blood sugar levels to target range. Again, pay attention only to the graph, okay? Here, it again shows that what we do during pregnancy seems to affect their insulin sensitivity, the Matsuda index, the obesity levels, all of it, independent of all the other variables which could affect these values, be it the child's BMI, the mother's BMI, okay? So this is for us to understand that hyperglycemia management is an extremely important job. It's not something where you start a tablet because it's easy and you send them home. We are altering what their metabolic blueprint of that child is going to be 10 years down the road. And then we lament about how NCD is increasing in children, adolescent diabetes is increasing in children, okay? I'll go back now to MIG tofu, okay? How effective is metformin? Roughly 46% of people who receive metformin required additional insulin to bring sugars under control. And this is a 2008 study. We were not even trying to achieve targets of, 90, 80. We were like, okay, if it is not hyperglycemia, it is good. That was the goal for MIG tofu, okay? But even then, 46% required insulin. So it's not a very efficacious way of controlling blood sugar levels. Now we have follow-up data for MIG tofu. They said, no, fat distribution is different. Visceral fat is reduced in the children who received metformin. Subcutaneous is greater. In the future, they are going to be at less risk. But now these children are also 10 years of age. And when you pay attention to their weight, notice that the children who receive metformin are heavier, have higher waist circumference, okay, and waist-hip ratio as compared to the women, children who are born to mothers who received insulin. And if you do body composition analysis, you will see that it's not offering any major benefit in terms of fat redistribution, okay? So there is no difference in the fat distribution. So there is no metabolic benefit for the future that you're giving by starting metformin to the mother. Please be very clear about this evidence, okay? What about safety? Sri Nagesh has been very nice to tell us all the details, okay? He also spoke about prematurity. He also spoke about small for gestational age. I'm going to skip through all of that, okay? But we will go, but a recurring signal which is coming from metformin, the strongest one is for small for gestational age. To all the gynecologists in the room, this is an important signal which cannot be ignored at all. And it is a category B medication, but if you can zoom in and understand what category B actually means, is that there are animal reproductive studies who fail to demonstrate a risk to the fetus, and there are no adequate and well-controlled studies in pregnant women. Or animal studies have demonstrated an adverse effect, but there are no studies in women to demonstrate a risk itself, right? And somehow we are comfortable giving this medication to all pregnant women, okay? It does cross the placenta, we know. Molecules which are involved in the transport of metformin across the placenta are exposed in the placenta, which helps transport metformin. And there is also accruing evidence to suggest that all the transporters which are important for nutrient delivery across the placenta can be downregulated in cells, placental cells which are exposed to metformin. So this is an important bit of information. And clearly nobody can explain in one single sentence how metformin exactly acts, but we do know it meddles with the energy sensor of the cell. And there is accruing evidence to suggest that important interaction could be affecting epigenetic programming. So if you notice, the 1-carbon metabolism is involved in methylation and histone acetylation. Those are two important steps involved in epigenetics of expression of genes. So could this be a potential thing? We don't know. There's also this point which Sri Nagesh alluded to. Beyond the point of metformin use, it can inhibit the mitochondrial complex, and it could cause a decrease in energy available in the cell itself, which could potentially explain, the SGA which is happening. The last point, but probably a point which is relevant to our lives, this is data from Dr. Yagnik's decades of research to show that B12 deficiency is very common. B12 deficiency with folate excess together could be an important micronutrient milieu which increases our risk for cardiovascular disease and metabolic health in children. He has generations of data to prove that. And we clearly cannot ignore the interference of metformin with B12 deficiency. So with the B12 deficiency and the fact that it can have a threshold effect on inhibiting mitochondrial metabolism itself, could we be actually increasing risk of future cardiovascular disease and diabetes by giving metformin by itself, leading to dual teratogenicity? He did say guidelines say give, but almost all guidelines are saying don't give and use insulin as the first mode. So quickly to summarize, the big message here is that understanding of management of hyperglycemia and pregnancy has evolved with data coming in from HAPO follow-up. Now the children are 15 years of age, saying what we do in pregnancy is important. It's an extremely important window for us to act to reduce the child's risk of obesity, diabetes, and cardiovascular disease. So if you are going to design a treatment with the child's future health in mind, you should be choosing the most effective, best available, safest molecule available. Why would we choose metformin? Okay, so I think I've provided all the evidence. First, we do no harm. Okay, and I hand back over to the chair.
Thank you, Dr. Chitra. Both have spoken wonderfully regarding the usage of metformin during pregnancy. Before having a balanced view, I asked Professor Anand Moses sir to have his own views.
Chitra, you said metformin is category B. Insulin is also category B.
I don't think so, sir.
All insulins are category B. So both contents, both said to be safe in animal studies. I mean, safe in animal studies, but not well proven in human studies. Nagi?
Thank you for making my job easier.
Can I just add that the category A to
Category
X
has
is
been given
no
up
longer
now.
used
Yes.
in care. Having said that, Chitra sock him.
Most of the time, when as diabetologists we see the patients, they are already started on metformin by the gynecologist. In that case, most of us add insulin and continue the metformin. But we as such don't start on metformin most often.
Sir, this should actually be a case of, it is never a case of one versus the other. Even if you look at the data of Rowan et al., he did say that 46% of them actually needed supplemental insulin, but if you look at it the other way, there were almost 50% of people who did not have to go through the trouble of using insulin.
And
As far as the epigenetic, as far as the subcutaneous fat is concerned, there is a small mechanistic understanding of this. Basically, what using metformin in early pregnancy in a woman with obesity does is, it causes fat cell hyperplasia. It increases the fat cell hyperplasia. The subcutaneous fat you see in all these children at the age of 9 years to 10 years is, there have been studies which have shown that this is hyperplasia and not hypertrophy. It is hypertrophy which is more dangerous as far as subcutaneous fat is concerned and future prognosis is concerned. And what metformin is driving it is acting as a sink for subcutaneous fat, increasing your number of adipose cells and mitigating the long-term consequences which can happen because of increased maternal weight. It is actually being protective rather than being harmful.
Requirement of insulin comes down drastically when patients require large doses of insulin. A small dose of metformin definitely reduces the insulin requirement. I don't know.
Can I have one more question?
Yes.
I want Chitra, can you highlight, which I think a lot of gynecologists fail to understand, is that the adverse consequences of metformin in pregnancies is even more in PCOS pregnancies. Right from Spencer et al., this signal has existed, but we have been consistently ignoring. Can you elaborate a little bit?
So the MIG-TOFU data is only looking at women who were exposed to metformin, let us say, later. Around 30 weeks of gestation was when it was initiated. But women with PCOS who have been exposed earlier, like Dr. Sri Nagesh also highlighted, did show that prematurity and SGA are more significantly reported. The MITI trial did also show that even in women with type 2 diabetes, the SGA risk was high. The MOM pod was a similar study which looked at women who got exposed to both metformin and insulin, but the study was not designed to look at SGA per se. So the request to gynecologists might be that maybe don't initiate metformin, maybe just reach out to the physician, endocrinologist, diabetologist as early as you can, so that we could maybe design treatment of hyperglycemia in a more scientific, safe, and more, maybe even a shared decision with the person itself, because once you start, it's very difficult for us to take them off it. So as Dr. Anand has highlighted, that is definitely a challenge. Over to the chair.
One question for Chitra. In the SGA versus the normal birth weight, insulin versus metformin, across various meta-analysis, what do you think was the actual weight difference between the two groups?
0.33 kg was the difference.
A majority of studies actually showed you a weight difference of only 68 grams, the latest studies. It was actually pretty low. 0.33 was in the earlier studies. In fact, some studies have actually given you almost 500 grams, but the latest studies show you a difference of weight of less than 100 grams. And the preterm was less than a week.
I think time up, we're going to conclude. As per the conclusion, metformin cannot be blindly continued during pregnancy. At the same time, we should not be absolutely withdrawn from the pregnancy. It has to be individualized. So as Dr. Chitra also pointed out, so we have to be careful while selecting the metformin in a pregnant patient. We have to individualize patient, whether this patient needed based on the clinical data, all these things. So you can use with caution, not with the fear.
I think I would like to say that we don't have to make it as a horror drug. I know a lot of obstetricians do use metformin. The preterm labor, we don't really see that many preterm labors, and like he said, the low birth weights don't really come over. But there is a small subgroup where metformin really works. But if you have a very high fasting, you have A1C which is very high, obviously metformin is not going to find its place because insulin is going to be combined along with it. So I think we need to individualize, like you said, you can't say one versus the other. Definitely metformin has its benefits, and even the heavier babies have been in very small studies. In practice, it doesn't really. And the problem is, I have to confess, that a lot of them will put them on metformin in PCOS. And when they conceive, they invariably continue it during the first trimester.
Has been shown to show less preeclampsia as far as the other drugs are concerned, especially ones who are continued on metformin. You are talking about the ones who were continued on metformin once they are on PCOS. Preeclampsia.
I wouldn't really want to comment on that.
Thank you. Over to Kauri.
Thank you, sir. Thank you, both the chairperson and speakers. We will move on to the next session. May I request Dr. Murthy sir and Dr. Rajalakshmi madam to chair the next session. Over to you, sir.
Good afternoon to one and all. Now, I thank the organizers and Dr. Krishna for giving me the opportunity to share this session along with Murthy sir. Now, after a very good discussion on a Sunday morning, now the most important aspect is the obesity epidemic and its effect on fertility. I would like to call upon the first speaker about the effect of obesity on female fertility. Welcome, madam. We are very eager and we want to, all of us know that prevention is always better. So we would like to hear from her views on obesity and how to deal with it.
Good morning, everyone. Thank you for inviting me to talk about how obesity affects fertility. So the objective of the session is obesity and its association with reduced fecundability, infertility, and adverse reproductive outcomes. And also explain the pathophysiological mechanism behind this and interpret the clinical evidence regarding the impact of obesity and its complication on natural conception, ART, and pregnancy complication, and also discuss about the evidence-based management strategies. I would also want to highlight the transgenerational implication on maternal obesity, but Dr. Vidya is going to talk about this as a separate topic. So, obesity is a powerful reproductive endocrine disorder. It is common, independent, and modifiable risk factor for female infertility, impairing both natural conception and ART outcomes. It is just not the excess weight. It is a state of metabolic dysregulation, chronic low-grade inflammation, and hormonal imbalance. These disturbances can disrupt the entire reproductive system from the pituitary, hypothalamus, ovary, oocyte, endometrium, placenta, and fetus. Childhood and early adult obesity increases the risk of persistent menstrual irregularities and later infertility. If you see the epidemiology, obesity is like increasing exponentially, more than 3 times increased over the last 4 decades. And 30 to 40% of women of reproductive age are overweight and obese. The rising obesity threatens the natural fertility and ART success. In India, you can see most of the states are more than 50% prevalence of obesity. The darker the color, the higher the obesity prevalence. So, infertility risk increases by 3% for every 1 centimeter increase in the waist circumference, and 2 to 4 times higher infertility risk, longer time to conception, higher miscarriage rates, reduced clinical pregnancy, reduced ART success, that is the live birth rate. Women with BMI of more than 30 have 3-fold higher risk of infertility. So if you see the odds ratio is between 3 to 3.3, it accounts for 6 to 12% of female fertility at the population level, and 2 to 3 times more common anovulation in obese women. 40 to 70% of the women with PCOS have major cause of infertility in obesity. And even in natural conception, plus 1 kilogram meter square of BMI above 29 reduces the fertility by 4%. And if you can see the pathophysiology, as I have discussed, it affects the HPA axis, adipose tissue. It can occur through insulin resistance, inflammation, reproductive dysregulated lipid metabolism can affect the ovaries and endothelium, mitochondrial dysfunction, and also dysregulation of biogenic amines. Before I talk about it in detail, I just want you, everyone aware of the normal ovulation where we need a pulsatile GnRH and coordinated FSH and LH surge where the ovulation occurs, and we need a progesterone for the proper secretory phase for receiving the embryo for implantation. So the problem everywhere due to obesity. So what happens? First I'm going to talk about the neuroendocrine metabolic disruption, the chronic inflammation. Leptin resistance, what it causes? Increased hyperinsulinemia. When insulin resistant and hyperinsulinemia happens, it increases the, decreases the SHBG and increases the estrogen, which affect the GnRH secretion, which again disrupts the LH and FSH. It directly causes anovulation, and also it impacts on the granulosa cells, and it causes poor follicular development, which leads to miscarriage and infertility. Then come to obesity. What happens in obesity? There are a lot of leptin in the adipose tissue, and due to increased aromatase activity, there is more conversion of androgen to peripheral estrogen, which again affect the GnRH pulsatile secretion. As previously discussed, hyperinsulinemia also increases the free estrogen, disrupts the GnRH secretion. So estrogen exposure is tonic, which means hypofunction. So actually estrone is the peripheral conversion. Estradiol is the more active hormone for LH surge and ovulation. But this estrogen, chronic exposed estrogen, is not much functional and which is insufficient despite normal or mildly elevated. which affects the follicular arrest because there is no LH surge, decreased FSH sensitivity, and in the ovary there is decreased granulosa aromatase. So lipotoxicity, high lipids is another risk factor in the obesity. What happens due to multiple mechanisms? So generally for the ovum there is a spindle formation, there is a microspindles which get arranged for the alignment of chromosome. When that microtubules are disrupted due to this mechanism, the chromosomal alignment will be also abnormal, so which causes the decreased or increased number of chromosome, which can affect the oocyte quality. So the aneuploidy can happen, which affects the fertility. So with multiple mechanism, the IVF success get reduced, decrease in fertility and decreased pregnancy rate. What happens in endometrium? So usually the estradiol and progesterone regulates the secretory phase. Because of this abnormality, the stromal decidualization, the differentiation that happened in the endometrium got affected. So decreased decidualization and placentation affect the embryo implantation. So this we already talked about. So disturbed GnRH secretion, incoordinated LH and FSH, and decreased estrogen progesterone. This is the top to bottom, the endocrine system get affected. In addition to that, we talked about the adipose tissue, liver, where it can also cause the hyperinsulinemia and inflammation. So what happens in ART and pregnancy outcomes? Dr. Usharam has clearly explained the many risk factors that is associated with obesity on pregnancy outcomes. So lower implantation, lower pregnancy rates and lower live birth rates with IUI and IVF. So increased risk of cycle cancellation and higher medication requirements due to obesity associated with higher miscarriage rates contributes to adverse pregnancy outcomes like gestational diabetes increases by 2 times and preeclampsia 2.2 times, and also fetal complication, there is increase in cesarean rates and increase in fetal macrosomia. So clinical challenges for both clinical management and ERT success optimization is required. So this is what we just discussed. Impact of obesity on PCOS. As obesity is growing exponentially, PCOS is also more common. Both together increases the risk of insulin resistance and also increases the risk of type 2 diabetes. It's a vicious circle exists where obesity worsens PCOS features and PCOS promotes further weight gain and metabolic dysfunction. So PCOS prevalence is higher in overweight and obese, around 28 times reported in some cohorts. Obesity amplifies cardiovascular risk factors in PCOS, including hypertension, dyslipidemia, even in young women. So in addition to fertility, this is also again risk factor for women in fertility. So this is just summary of what can happen in PCOS and obesity. And I'm not going to go through everything. So it affects the fecundability, gonadotrophin requirement, decreases the implantation rates, increases the miscarriage, and also decreases the live birth rate, higher cycle cancellation, gestational diabetes, and hypertensive disease. So the combo of obesity and infertility, it is again a bidirectional cycle. Infertility promotes weight gain through psychological stress, depression, emotional eating, and reduced physical activity. Obesity worsens hormonal, metabolic, and reproductive function, further impairing fertility. So obesity and infertility therefore form a self-reinforcing vicious cycle rather than one-way causal relationship. Psychosocial feedback mechanisms are frequently underrepresented in biological models in infertility. So it's just not the obesity that affects the fertility. So what is associated with obesity? We have MASLD, we have obstructive sleep apnea, type 2 diabetes, hypertension, preeclampsia, dyslipidemia. All these are individual risk factors, and again in combination with obesity affects the fertility, pregnancy outcomes, and neonatal outcomes. So gut dysbiosis is also associated with obesity, which again affects the disrupted ovulation, endometrial receptivity, and immune intolerance. Psychological stress and circadian disruption just we discussed. And if somebody is on multiple medication, increases the metabolic disease. So again there is a delayed conception, rebound, and weight and metabolic instability due to this. So if somebody associated with microvascular disease, CKD, with obesity, this again affects the anovulation and implantation failure. Epigenetic, Dr. Vidya will be covering it, so I'm not going to go through about it. So I've just summarized this slide. So economic and social burden, obesity-related infertility imposes substantial healthcare cost due to repeated investigation, assisted reproduction and pregnancy implication. Infertility-related stigma and social pressure remain insignificant in many cultures, affecting mental health and care-seeking behavior. The combined medical, psychological and financial burden makes obesity-related infertility a public health and health equity issue, not solely a clinical problem. So the psychological impact of obesity and infertility. So the infertility itself increases the risk of depression, anxiety and stress disorder. In obese infertile women, again there is increased risk of depression, sexual dysfunction and anxiety. So obesity often coexists with low self-esteem and body dissatisfaction, worsening psychosocial outcomes. Why weight loss works? We need at least 5 to 10% of reduction in body weight so that we can restore ovulation, menstrual irregularities, reduce insulin resistance and decreases the circulating androgens, increases SHBG and normalize the hormone and improve response to ovulation induction and assisted reproduction so that we can reduce the pregnancy and obstetric complication. But if somebody has a long-standing obesity, we may not be able to reverse the quality of the oocyte to the maximum. So during preconception, it's very important, preconception counseling is very important because we have to explain and counsel the obesity related problems and tell them it's important at least to have a 5 to 10% weight loss to improve fertility. And when they come to us, we assess for the clinical risk, associated comorbidities and required investigations will be carried out. And like yesterday we talked about a lot of dietary and physical activity for improving the obesity. The lifestyle measure is the first line for improving the obesity, and sleep optimization and stress management is also important, which we have to discuss. So in this study, in this meta-analysis, you can see the pregnancy rates decline with increasing BMI in PCOS from 41% in normal weight to 70% in class 3 obesity over 3 years. And women with BMI more than 40 have a 63% lower chance of pregnancy. So the 10% weight loss increases the likelihood of pregnancy by 68% in women with baseline BMI 40. The hazard ratio is 1.68. So it's very important in people with PCOS and obesity to lose weight to improve the pregnancy. So the lot of questions about metformin that people do ask. Can we use metformin in obesity? There are many trials show that average of 2 kilogram over long follow-up, but this varies, and in some group there may be up to 5 kilogram of weight loss for someone around 100 kg if they treated for a year. So this happens especially in people with insulin resistance, PCOS or obesity. So the metformin increases the ovulation compared to placebo, but does not reliably improve clinical pregnancy rates or live birth rates, inferior to oral ovulation induction agent. So this cannot be considered as a first line for ovulation induction in PCOS. We've got letrozole, clomiphene, not metformin. So it's an era of GLP-1 receptor agonist. There are many people who is using it, and most human reproductive benefits observed are strongly correlated with the weight loss treatment because it improves the insulin sensitivity, making it difficult to isolate direct effect of GLP-1 agonist in the ovaries, endometrium or in the HPA axis, because there is not much studies yet to prove it works independent of the weight change. And we also have less data outside the PCOS and even in normal weight women. So what is the rationale that it may have a direct effect is GLP-1 may act centrally to modulate GnRH and LH secretion, which regulates ovulation. There are receptors in the ovaries and endometrium can suggest potential direct tissue effects, but we have less human studies. And this is a systematic review. In addition to the usual effect of weight loss, insulin sensitivity, and reduced inflammation, and reduced androgen excess, and restoration of GNH pulsatility, in this study there is a pilot IVF trial where they looked into 28 women who was on, one arm was metformin and one arm was metformin and liraglutide. And if you see, the success rate of percentage is 85.7 versus 28.6 in the metformin plus liraglutide groups. But this is significantly higher than the comparable weight loss. So there may be direct effect, but we need more and more studies to look into this. And also, when they use, there is a, in animal studies, there is a dose dependent toxicity for the fetus. So we have to be very careful. So it's not recommended during pregnancy, and we have limited data in normal weight and non-PCOS women. So GLP-1 receptor agonists are promising metabolic fertility adjuvants in obese women with PCOS, but should be used cautiously and discontinue before the conception, ideally 2 months before the conception. So as previously mentioned, semaglutide and tirzepatide, we are waiting for the outcome. Still now we haven't got any study showing improved pregnancy rates published yet. But observational and anecdotal reports suggest that weight loss from these drugs may indirectly improve fertility via restored ovulation, but we need a proper RCTs regarding this. So more and more people are using GLP-1 agonists. Like if you see, the Ozempic pregnancies are increasing, and in US it's around 659% use has increased. But weight rebound after stopping GLP-1 receptor agonist may worsen the pregnancy risk. So we need more data in the human studies. And in human evidence, according to several data, till now there is no teratogenicity, but we need a proper studies. But in the animal data, we have seen there is a risk on the fetal toxicity. Regarding pregnancy outcomes, we have a mixed data. So some cohorts have said increased high blood pressure, decreased preterm and decreased blood pressure. In other data, there is increased gestational weight gain and NICU admissions post GLP-1 receptor agonist therapy. Animal evidence put fetal toxicity fetal exposure in pregnancy is associated with decreased fetal growth, placental structural changes, skeletal and cardiac abnormalities, altered neurodevelopmental like hypothalamic wiring. Effects often dose and timing dependent and sometimes linked to maternal weight loss. So if we continue GLP-1, there may be a maternal weight loss which could be harmful for the pregnancy. So we just talked about the gestational weight gain. So many of us are prescribing GLP-1 or combination GLP-1 GIP. And this is the study where they used this medication in the last 3 years before the conception and continued till the early pregnancy. And you can see it's a sample size is around 448 for a GLP-1 exposed group and 1,344 for unexposed group, where pre-pregnancy BMI is around 36, pre-existing diabetes is 23% in the exposed group. You can see the gestational weight gain of around 13.7 in the exposed group, whereas in the non-exposed group 10.5. So it has increased, and also excess gestational weight gain increased by 65%. Hypertensive disorders of pregnancy is 46 compared to 36 in non-exposed group. And if you see the preterm delivery, 17% compared to 30% from the non-exposed group. Gestational diabetes, 20% compared to the 15% in the non-exposed group. And disorders, the hypertensive disorders of pregnancy is 46 compared to the non-exposed groups. Cesarean delivery there is no difference. So the question comes, in the assisted reproductive therapy, do we have any BMI cutoff? So according to the Indian guidelines, there is no formal governmental mandate, but most people use the cutoff between 30 to 35 kg per meter square as an upper threshold for initiating ART. And also it's a case-based risk assessment depending on the BMI, safety of anesthesia and comorbidities. We have a nice guidelines who usually keep the cutoff They aim for cutoff below 30 for the NHS funding, maybe use till up to 30 to 35. Similar, the Australian practice also. Post-bariatric surgery, we can see the bariatric surgery reduces infertility, menstrual irregularity and miscarriage by around 70 to 8%. So IVF outcomes after bariatric surgery are comparable to non-operated women of similar BMI. So sustained reproductive and metabolic improvements are observed in PCOS through larger trials are needed. So post-bariatric, we have to wait for at least 12 to 18 months before we plan for pregnancy. This allows time for stabilization of weight and correction of micronutrient deficiencies that could adversely affect the fetal growth and maternal health. The most of the guidelines is said the targeted treatment and individual risk assessment. It is very important to do the obesity counseling pre-conception. So to conclude, obesity is a modifiable risk of infertility. Early weight optimization, metabolic correction, individualized fertility strategies and integrated psychological support substantially improves the reproductive outcomes and long-term health.
Thank you, Dr. Leelavati. I think she has covered all aspects of obesity and stressing mainly on the preconceptional aspect. And I think we need a high degree of motivation for people who come to the infertility clinics. And also another thing is we have to catch them young. So maybe like iron supplementation programs which has started in adolescent, maybe we have to start from the school levels or college levels. Thank you, Dr. Deva.
Thank you very much.
Thank you for that lucid presentation. We'll have the discussion at the end of the 3 talks. Please do join us here on the stage. Dr. Leelavati, you can join us. The next talk is going to be delivered by Dr. Muthukumaran Jaipal, and the topic is the impact of obesity on male subfertility. Dr. Muthukumaran Jaipal, well-known endocrinologist, is a consultant endocrinologist at ARCA Center for Hormonal Health Private Limited, Chennai. Over to you.
Thank you, sir. Good afternoon, everyone. It's my pleasure to be here. My task has been cut short by Dr. Leelavati already because we are going to see the other side of impact of obesity on fertility, male infertility. And I'm not going to dwell on this, but we all know that obesity is a global health crisis in today's world, and we've spoken a lot about GLP-1s and how things are changing. But we assume or presume that about 40% of the world's population is going to be obese by 2030. So this is going to cause a pandemic of cardiovascular disease, diabetes, cancer, but it will also lead to more subfertile or infertile couples. And we are just going to look at how this is causing this. But in a nutshell, the worsening insulin resistance, inflammatory pathways and oxidative stress are predominant pathways. So causes of obesity per se: overnutrition, psychological stress or busy lifestyle. Smoking, alcohol and drugs can cause patients being overweight, but this also leads to a number of factors like systemic inflammation, physical disorders, insulin resistance, genetic and epigenetic changes and leptin resistance. So this put together causes oxidative stress leading to male subfertility. And the pathways, how it works is obesity increases scrotal temperature, causes erectile dysfunction, increased germ cell apoptosis, sperm DNA fragmentation is increased, and altered seminal parameters due to obesity. And as we get obese, with the BMI going up, your odds ratio of being subfertile becomes more, and there is almost a 1.3 to 1.5 fold increased risk of subfertility in men with obesity. And this also leads to low sperm count, and this is one large meta-analysis which showed just the risk of being overweight makes your odds ratio of 1.28 for low sperm count, which is aggravated by being obese to 2. So what happens in obesity? Low-grade systemic chronic inflammation is what happens. So if you look at any organ from the hypothalamus, heart, pancreas, adipose tissue, liver, everywhere there is increased inflammation causing increased atherogenesis, your GnRH pathway is altered, there is increased pancreatic and hepatic steatosis causing worsening of insulin resistance and inflammation. And then the testicular effects which I've discussed, leading to increased inflammatory cytokines, leading to a obesogenic environment, worsening of the inflammatory pathway. So what happens exactly when with the sperm analysis? Oxidative stress and DNA integrity goes down. There is a twofold decrease in sperm mitochondrial activity, and DNA integrity comes down. The oxidative stress also has a direct relationship between the seminal plasma levels, and with increasing BMI, your seminal fluid is altered so that there is subfertility. As I said earlier, DNA integrity goes down and decreased sperm DNA integrity in most studies which has been looked at, and increased apoptosis, and there are proteomic changes both for obesity and diabetes. So to put together, obesity causes lots of physical disorders, genetic disorders, hormonal disorders, which we are not talking about today. We are talking about simple obesity, which causes erectile dysfunction, altered seminal parameters, and subfertility. So the mechanism one, how it reflects is a primary endocrine defect in your male obesity, independent of having hormonal issues or independent of having sleep apnea. This is an extra cause. So this is simple obesity causing mild hypoandrogenism due to complex disruption of the feedback mechanism. So your LH-FSH pathways are altered. So naturally, obese individual starts to produce low testosterone, which we call as reversible hypogonadism. The other causes for the same is hyperinsulinemia, which is insulin resistance with altered sex hormone binding globulin. There is also excessive aromatization leading to increased estrogen in the system, thereby changing the testosterone estrogen ratio, and so on. To put things in a nutshell, which leads to reduced total testosterone, reduced sperm count and vitality, and decreased inhibin leads to low Sertoli cell function. The second part is it causes other metabolic changes in your adipose tissue. It secretes hormones which is leptin and other cytokines which actively disrupt the reproductive axis and testicular function. So as I discussed early on, insulin resistance, leptin dysfunction, and inflammation causing increased pro-inflammatory cytokines leading to increased TNF alpha and interleukin 6, thereby leading to decreased spermatogenesis as well as decreased libido. There is a big pathway of oxidative, thermal, and DNA integrity which happens in an obese environment. So the environment becomes hostile to sperm production, and a combination of physical stress and chemical oxidative stress, which works through the oxidative stress, causes decreased sperm integrity, leading to excessive DNA fragmentation due to nucleus damage of the embryo. And there are other things like lipid peroxidation and acrosomal damage, which aggravates the sperm counts. So what happens to sperm semen analysis? You get decreased concentration due to obesity, progressive motility of the sperm becomes low, and morphology and decreased function of the normal forms is also down. When you have improvement in weight through lifestyle interventions, the progressive motility changes dramatically back to normal, whereas the morphology almost remains the same. Weight loss through good means also improves the DNA fragment index, which improves fertility. What happens in the adipocytes? The adipocyte, as I said earlier, leptin, adiponectin, and resistin. This is almost very similar to our insulin resistance pathway, causing disorders of glucose metabolism and reproduction. But excessive leptin decreases your Leydig cell function and has direct negative effects on the sperm. The inflammatory markers like IL-6, TNF alpha leads to increase nitric oxide production and aggravates further oxidative stress. Aromatase polymorphisms are known to aggravate this, and some group of patients are more prone to increase estradiol levels than other people. I won't dwell on this, but you need to keep that in mind. And the most three common mechanisms involved, as I said, are oxidative stress, hormonal imbalance due to obesity, and accumulation of endocrine disruptors. And how do we modify this? We have treatment modalities like lifestyle and nutritional changes, which predominantly is calorie restriction, pharmacological interventions like drugs, weight loss drugs. Aromatase inhibitors can be used in a select group of patients, which we will look into that in the next few slides. Surgical intervention like scrotal lipectomy and bariatric surgery will help, and ART techniques can also be useful in the final stages. So, if you're obese and you follow a good lifestyle and you improve your weight through good lifestyle changes, most of these changes are irreversible. Your hormonal change is back to normal. Your DNA fragment percentage is back to normal. And your hormonal profiles also, provided you do not have any confounding risk factors. Does medication improve semen quality? Yes, if there is an altered testosterone to estradiol ratio, then you can use anastrozole for aromatase hyperactivity, which alters the T to estradiol ratio back to normal, which can help in a select group of patients. And the dosage what we use in patients is about 1 milligram QID for 3 to 6 months. And if you see, by altering this ratio, you get testosterone back to normal, ejaculate volume improves, and sperm count also improves. So this might be applicable in a small group of patients. In male hypogonads who are hypogonadic, we can use HCG as a stimulator. We can use 250 milligrams twice a week, and for improving, you can use it as a 3 to 6 monthly course for obese individuals. Bariatric surgery is a little bit tricky because some of the studies have failed to show significant changes, and there is an acute phase post bariatric surgery, as Dr. Leelavati was saying. The first year is tough. You get no sperm quality or quantity changes. There might be occasional worsening of the sperm count as well immediately post bariatric surgery, but these changes we expect once the weight stabilizes and the patients move from a catabolic to a stable phase. This should work in the long run. So you have to be careful in the first year post bariatric surgery and not be disappointed with the limited changes. ART techniques can be used in these individuals, and the likelihood of pregnancy in IVF is decreased if your male partner is obese or overweight, and the success rate also depends on your weight. So giving them good lifestyle changes will improve ART success rates, and the higher the weight loss, the better your success rate. What can we do about other things? Diet and exercise is universal to all our patients who are trying to lose weight. As I said, aromatase hyperactivity can be addressed through medications, and if patient is morbidly obese over a BMI of 35, bariatric surgery or one of the new agents like GLP-1s can be used, and you can also use ART techniques. So to put together, obesity can negatively affect male fertility by reducing testosterone levels, sperm count, compromising DNA integrity, and diminishing overall sperm quality. While addressing sperm issues related to obesity and male infertility, it's crucial to consider good lifestyle changes, medical interventions, and other surgical options. And we have not discussed primarily hypogonadism by hormonal means, but what we have looked at is primarily obesity-related changes in hormones. So bariatric surgery may as well complement lifestyle changes and medical management. So when obesity is linked to subfertility, it is essential to tease out if there are any medical disorders, If they are, then we need to address them. If they are not, then our discussion is to just address through lifestyle changes and use drugs as and when needed. Thank you so much.
Thank you, Dr. Muthukumaran, for that erudite presentation. Please do join us. The third talk is by Dr. Vidya Jagidhar, and she's going to talk on transgenerational imprinting in obese pregnancy. Your CV is not there. Is the CV on? No. Sorry. I think you should introduce yourself and then start. Yeah, sorry.
I'm
It
Dr.
just come
Vidya.
on. Consultant diabetologist and endocrinologist at Covey Medical Center and Hospital, Coimbatore.
And thank you, sir. I think we've heard enough about obesity for the last 48 hours. So I'm not going to bore you with a lot of statistics. But this is an interesting topic because this is the future and all the research is going to be focusing on prevention of complications in the fetus. So my topic is on transgenerational imprinting in obese pregnancies. I do not have any conflict of interest to declare. So the prevalence, we all know, has tripled over the past 4 decades. The prevalence of overweight and obese Indian children is going to be 15%. That's a lot. And 1 in 10 obese children globally is going to be from India in the year 2030. So that's a lot, 1 in 10 children. So how do we explain the rapid global rise in obesity? Can this be attributed to just genetics or poor lifestyle? Or is there a more complex mechanism to this that we are trying to understand? And what is the evidence we have for this? So the objective of my talk is to explore the epigenetic mechanisms linking maternal nutrition to offspring adiposity and metabolic disease, examine how major classes of environmental toxicants reconfigure the fetal epigenome to promote obesogenic phenotypes, evaluate the evidence for transgenerational imprinting, and to identify the knowledge gaps and preventive actions at mitigating the intergenerational cycles of obesity. So what do we mean by transgenerational imprinting? I need to explain a bit of genetics because any article you read on transgenerational imprinting or fetal programming or developmental origin of adult diseases, they will talk about epigenetics. What we mean by transgenerational imprinting is, to keep it very simple, if the mother is pregnant with a female child, the oocyte of that child is going to be inheriting the epigenetic modifications. So that is the third generation, the F3, which is not directly exposed to the stimulant or the endocrine disruptors or obesity or any of the triggers. So it's the third generation that gets affected without directly being exposed. That is transgenerational imprinting. So what evidence do we have? Most are from the animal studies and epidemiological studies in humans and longitudinal cohort studies. We do not have randomized control trials. It's very difficult to take a sperm and ovum and do a randomized control trial. So we have long-term follow-up studies. So what is epigenetic modification? So think of your DNA as your anatomy textbook or Harrison's. That's not going to be changed at any time. So the textbook is the same. And the epigenetics is like putting sticky notes to different pages and giving us a choice to say which pages are important, which one to read and which one you can skip. So that is epigenetic modification. And there are 3 types of epigenetic modifications that if you read any article, it's going to be repeatedly being discussed, is DNA methylation, histone modifications, and non-coding RNA silencing. So what is DNA methylation? It's an epigenetic process where a methyl group gets attached to the cytosine bases by the enzyme DNA methyltransferases. This enzyme is important because there are studies ongoing looking into these epigenetic modifiers. So what happens is that this process is called methylation. Once methylated, the transcription of gene is blocked. So this can control adipogenesis, triggers the differentiation of pre-adipocytes into mature fat cells, and also regulates the browning of white fat, where a process where fat cells burn energy instead of storing it. So methylation, DNA methylation is just switching the gene on and off. It also regulates the expression of inflammatory cytokines, like Dr. Muthukumaran sir has said, interleukin 6 and TNF alpha. Histone modification. Again, what are histones? These are proteins and they help wind the DNA tightly. It's like packing the DNA and they put them safely into the chromosome. Depending upon how tightly or loosely the DNA is wound around the histone, the genes are expressed or on or off. So it helps control the genes in active and different cells, involved in DNA repair process, cell division and development, and it's linked to cancer, neurological disorders and obesity. The third is the microRNA alteration. This helps in differentiation of the mesenchymal stem cells to adipocytes, and also biosynthesis and release of the bioactive factors, and also how the different genes are expressed in different organs such as the liver, the brain, pancreas and the adipose tissue, and it is responsible for insulin sensitivity, chronic inflammation, lipogenesis and adipocyte differentiation. So these are the three epigenetic modifications, and how we inherit this could be through the oocyte epigenome and the sperm epigenome, like the previous speakers have explained, but also through the fetal germline epigenome and as such the fetus, like the F3 generation. It can influence the uterine environment by fetal undernutrition or overnutrition, maternal diet, paternal diet, and all many other factors such as the damaged mitochondria, maternal cytokines, microbiota, breast milk, all have been implicated in this epigenetic modification, leading on to changes in the leptin melanocortin pathway or the nutrient transport genes or the imprinted genes, leading on to obesity. So this is the developmental origin of health and disease, and what they did, this is a natural study. So the famine was caused by the Nazi blockade in 1944-45, and the women were only allowed 400 to 800 kilocalories per day for many months. And this became like a natural experiment, and when they studied, they found that the gene insulin growth factor 2 played a crucial role in the fetal metabolism, and the fetuses who lacked this IGF-2 were found to be growth restricted and hypoglycemic. So poor maternal weight gain has been associated with increase in leptin receptor methylation in the newborns. This leptin receptor is reduced expression in the umbilical vein, leading on to predisposition to obesity. The critical window is that the pregnancy-induced methylation changes persisted postnatally into adulthood, leading on to metabolic disease in the children, in the offspring, and this is the thrifty phenotype hypothesis. How about the maternal pre-pregnancy obesity? This has been shown in the effects in the mother and in the placenta, inflammation, chronic inflammation, pregnancy-related complications, altered gut microbiota, placental morphology has been changed, inflammation, chronic inflammation in the placenta itself, lipid accumulation and oxidative stress in the placenta, and they seem to have a slightly sex dependent differential effect in the offspring that has been studied in the rodents, where the men seem to have more compromised mitochondrial respiration, increased adipocyte area and impaired glucose tolerance, while the female offspring has got increased insulin secretion, developed hypertension and increased anxiety. But there are human studies looking into high fat diet and high sugar diet during pregnancy, and they seem to influence the PPAR gamma pathway and the IGF-2 insulin receptor sensing pathways, and leading on to increase in adiposity, insulin resistance, fatty liver and cardiovascular disease in the offspring. So there are many longitudinal studies. As I said, there is no randomized controlled trials, but longitudinal studies in different parts of the world. I'm not going to go into the details. How about gestational diabetes? We've been talking about GDM all morning, but one point I wanted to make is that the risk to the offspring remains significant even adjusting for the maternal and childhood BMI. confirming that the intrauterine environment itself, it's not just the shared genetics or lifestyle that programs the metabolic risk. It is just simple hyperglycemia. But we do not have evidence for transgenerational data in humans. It does not go, we don't know if the F3, the grandchild, gets affected by the hyperglycemia. We know that the obesity affects, that gets translated to third generation, but we don't know, we don't have long-term human data to explain gestational diabetes. But what's interesting is that we have always been promoting breast milk, lactation, for at least a year minimum. And what they found is that microRNAs are being secreted in the breast milk, abundant. Some of these microRNAs I mentioned that target DNA methyltransferases, and they found is that adopted siblings who had the same mother's milk inherited similar epigenetic pattern, and they seem to favor preventing NAFLD and obesity. So if the pre-pregnancy BMI is normal and the mother breastfeeds the baby, then the metabolic benefit to the fetus is going to be great. Not to mention the endocrine disruptors, we know all this, but we seldom discuss this to our patients. So endocrine disrupting chemicals are just chemicals that mimic the natural hormones, work at the nuclear receptor and interfere with the action of the hormones. We have documented that several endocrine disrupting chemicals such as the parabens and sulfates which are there in the chemicals, bisphenols, the BPA which has been banned, which is there in the plastic bottles, have been found to be more in patients with polycystic ovarian syndrome in US when they did a study on the urine samples of PCOS women. There are disinfectants, pesticides, solvents, vinyl fluorine, all these have got endocrine disrupting chemicals that differentiate the mesenchymal stem cells more into adipocytes rather than the osteoblasts. So the more and more adipocytes are being formed through the PPAR gamma pathway. And when should the child be exposed? That happens in the prenatal period during pregnancy, where there's enhanced adipogenesis, organogenesis, and the reproductive system development, and this continues postnatally as well until adulthood. So in a country like India, remember there's health inequality, maternal malnutrition, health unawareness, and a lot of endocrine disruptors that we do not talk at all. Imagine what the fetal outcome is going to be. How do we prevent this? What do we do? So to some extent, we can reverse these epigenetic changes. We need to have an integrated clinical approach. It's not a one person's job to do this, but it should be a combined effort of the obstetricians, pediatricians, physicians, endocrinologists, diabetologists, whoever is looking after the patient, starting from preconception, pregnancy, postnatal, childhood to adolescence. The 1,000-day window, that's very important. Consumption through the first 2 years of life, that is very, very crucial. So pre-conception counseling regarding screening for obesity and its complications, significant weight reduction, exercise to some extent modulates the DNA methylation patterns. Bariatric surgery pre-pregnancy. What the studies have shown is that mothers who undergone bariatric surgery pre-pregnancy, they seem to have a 52% lower risk of obesity in the offspring. So if the mother is very obese, perhaps offering bariatric surgery and the epigenetic modification as a result can help produce healthier offsprings. Timing is very, very critical. Of all the spectrum, the duration, pre-consumption intervention is the most effective. There is some evidence for nutrient supplements, not great lead of evidence. B12, methionine, folate, betaine, and choline seem to bring about some epigenetic modification, but the outstanding question is when to give, how much to give, and at what dose. Pregnancy, we have discussed gestational weight gain, GDM screening, nutritional assessment, avoid high fat, high carb diet, but to monitor the fetus for IUGR and macrosomia, which leads to adverse fetal programming. Postnatally, promote breastfeeding. Weight loss, encourage loss of the weight gain during pregnancy so that we can prepare the mother for subsequent pregnancies. Childhood to adolescence, early BMI tracking, family history assessment. This has to be done by the pediatrician at every visit they see the child. Lifestyle interventions should be early, prevention of obesity in childhood. Metabolic screening should start at an early stage for offsprings who are large for gestation or small for gestation, or mothers, parents with obesity. Parental education, inform about the transgenerational metabolic programming and endocrine disruptors. What are the future therapeutic frontiers? Natural phytochemicals are being studied as epigenetic machinery. DNA methyltransferase inhibitors and histone deacetylase inhibitors are being studied. Cell reprogramming, emerging adipocyte-focused epigenetic therapies are being studied. Outstanding research question and limitations of all the data that we have is that we do not have tissue-specific data. Most epigenetic data is from the blood. We don't know what's happening at the adipose tissue level. We do not know that the methylation changes are the result of obesity or the cause for obesity in these offsprings. We do not have long-term longitudinal data because we have studies going up to adolescents from the HAPO study. We do not have enough data to say if GDM is transmitted to the third generation. Human gamete studies are limited, or we don't have much because of ethical reasons, and epigenetic modifiers in clinical trials for cancer and obesity have shown that though some of the genes can be suppressed, it seems to increase the expression of some of the other obesogenes and can cause paradoxical obesity. So that's a bit tricky as well. So the key takeaways from my talk today is that childhood obesity results from complex environment, genetic and gene interaction, and it's not a single gene issue. Transgenerational epigenetic inheritance affects at least 3 generations or more, leading to deranged appetite regulation, metabolic changes and organ damage in the offspring. Critical window for preconception, pregnancy and lactation offers opportunities to prevent via epigenetic reprogramming. Lifestyle modifications to some extent can reverse epigenetic changes. Simple interventions are always highly impactful. Thank you very much for this opportunity.
Thank you so much, Dr. Vidya. Do join us on the stage. I think we have had a very interesting discussion by 3 speakers over the past 1 hour. The message first is obesity is a major problem as far as fertility is concerned, no doubt about it. And both Dr. Leelavati as well as Dr. Muthukumaran pointed it to it. And it's very important that weight reduction by lifestyle methods, and if required, intervention by drugs are required before someone is sent for ART. Because many times the weight gain or the obesity is ignored and therapy for infertility started. That's very, very important that they are corrected. And coming on to Dr. Vidya's talk, this is the future. And as you very clearly highlighted, the problem doesn't stop with the mother, not the fetus, not the infant, because it moves on to the next generation. Metabolic as well as epigenetic changes are passed on to the next generation. And so even if you have a healthy child born and the child has good lifestyle, the obesity can go on to the next generation. So it's very important it's corrected. You talked also about supplements, you talked about endocrine disruptors. On a lighter vein, where are we with the pollution now? Air quality index is so bad now in most part of the country. Now I think that's also a very major factor we have to. Now I think the 3 talks are open for discussion.
I am sure all of you must be having a lot of questions. From my side, are there any markers for inflammation to detect early for especially children? Any inflammatory markers which may be of any help?
I think it's only at the research level where they look at the TNF alpha or interleukin 6, but I don't think so there are any markers that will be of clinically of any use, like blood markers or tissue markers, that we can do a test and say this child is at risk. So it's multiple factors that we'll have to look into: maternal obesity, paternal obesity, and family history, and what was the weight of the baby when the baby was born. So again, we're talking about metformin in early pregnancy. So we'll have to think about the fetal programming happens in utero. And the first few weeks decides, if the baby is going to be growing up to be a big baby or small baby with metabolic disorders or nervous system problems. There is no one clinical marker or a blood test that we can do to predict if this offspring is going to have a problem in the future.
Any questions? I think all the three speakers should be congratulated for a wonderful presentation they made. And I think we'll close the session. Over back to the organizers. I think we have finished on this hall B.
Yes, sir.
Eh? So you can have a valedictory function here itself before we move on to hall A.
Thank you, sir. Thank you all. So the scientific sessions are still on hall A. We all can move to the hall A. Thank you all for joining us here.